Now we have the inaugural session of the seminar, and we have our honorable guest on the stage, Vaidhi Rajesh Kottachaji, Secretary, Ministry of Ayush, Government of India, Sri APM Mohammad Anish IAS, Principal Secretary, Industries, Government of Kerala, Dr. PM Warrior, Managing Trustee and Chief Physician, Ayurveda Kottakkal, Sri K. Harikumar, Chief Executive Officer, Ayurveda Kottakkal, Dr. K. Lekha, Superintendent, Charitable Hospital, Ayurveda Kottakkal. We welcome you all, sir.
Is a beacon of Ayurveda, blending the wisdom of ancient medicine with modern innovations. Thousands receive healing through Ayurveda and allopathy without ever worrying about the cost. This is the legacy of compassion passed down by visionary Dr. P.S. Warrior, guided by tradition. Ayurveda is more than just medicine. It's a way of living, healing, and connecting with the world around us. From humble beginnings.
Thank you, sirs and madam. Let us have an auspicious beginning for the program with a prayer. May we invite Dr. K.V. Rajagopalan sir for rendering the prayer.
Purnoshnishavadamsam mrududhavalapadivaravanottariam rupyodyadvetradandasphadigamayapidhanavritamilitaksham kale kale Karampuruhamukula Dhanvandarim tam Dhyayamyacharyavariyam hridi Lalitakalakovidam Vaidyaratnam.
Retired Professor, VPSV Ayurveda College Kottakkal, who left us for their heavenly abode in the past few days.
Let us resume the session. Now, may we invite Sri K. Harikumar sir, CEO Ayurveda Kottakkal, to deliver the welcome address.
Honorable Managing Trustee, Dr. PM Warrior, Kottakkal Sahab, Secretary Ayush, Hani Sahab, Principal Secretary Industries, Dr. Lekha, dear invited guests and friends. Today, on the occasion of the 61st Ayurveda Seminar, I would like to start by paying homage to the great physician, Dr. P.S. Warrior. A small step for a man, but a giant leap for mankind are the famous words of Neil Armstrong when he stepped onto the moon. I cannot find a better line than this to describe to the initiative of Dr. P.S. Warrior more than 100 years ago. This initiative by Dr. P.S. Warrior in starting Kottakkal Ayurveda Shala has laid not only the foundation of this great institution, but also has made Ayurveda a preferred option for the world. This initiative, which started by disrupting the then prevailing system of treatment in Ayurveda, right from sourcing of herbs to formulating of products like kashaya, ensuring the quality, because otherwise herbs standardization was not possible. So ensuring the consistent quality of the product, Starting from there, he went on to secure prompt supply chain of the raw materials and finished goods, even incentivizing same-day delivery, engage in community participation by encompassing all the agriculturists and farmers in the vicinity, and even ensuring that the payment gets done on the same day, encouraging arts and culture, and above all, giving something back to the society by putting up a charitable hospital when CSR as a concept was unheard of. This is a man who has lived ahead of his time. But Ayurveda Seminar has walked many a mile since then. And as you have seen on the wall, Ayurveda Seminar has today emerged as a great institution. We treat almost 1.8 million patients every year. We have more than 2,000 dealers pan-India. We have 850 distributors. And this premises where we are standing, that is the charitable hospital, itself has treated more than 2.2 crores of people since last 50 years, and all free. And out of which 1.4 crores is only in Ayurveda. That itself shows how great an institution has been built up over a period of time. But the story doesn't end there. Now we are actually building on the strong foundation. We have strong research wing. We are actually encouraging research in Ayurveda. And apart from that, we have a tie-up with NABARD to encourage farmers to take up cultivation of medicinal plant, which is in line with the vision of the Honorable Prime Minister in doubling the farmers' income. We are running projects along with CCMB, Hyderabad, for development of antiviral and neurodegenerative herbal formula, epigenetic markers against breast cancer with CFTRI, photodynamic therapy using natural products in collaboration with University of Johannesburg. We are running an Ayush Center of Excellence project. We have tie-ups with CES Hyderabad, IIT Madras, and the story goes on. We have developed almost 32 products in 23-24. Continuous process improvement and the production improvement programs are on. Around 32 formulation has undergone trials and are at various stages of commercialization. And as Secretary Ayush has said in a meeting, Ayurveda has grown from $2.85 billion to around $24 billion now, and Ayurveda is going to grow up to $240 billion in another 10 years' time. So I wanted to assure on behalf of everybody in Kottakkal to the Secretary Ayush that we will be very much part of the journey, and we would contribute our might in taking Ayurveda to great heights. Now let me get on to the job of inviting the dignitaries. Let me first of all welcome our Honorable Managing Trustee, Dr. P.M. Warrier, who doesn't need an introduction to the Ayurvedic fraternity, not only here, but of the country as well. This great physician has always been receptive to ideas and approaches and is leading the organization to great heights. Whatever you are seeing the organization today, the credit goes to him. I welcome him to this program. Our Secretary, Dr. Rajesh Kotecha, Padma Shri. He is a Padma Shri Award winner and he is a former Vice Chancellor of Gujarat Ayurveda University. He is also an author of books in Ayurveda. He is a pride to all Ayurveda physicians and has scaled many heights and has reached the position and is donning the position of Secretary Ayush. It is an honor not only to him, but the entire Ayurveda community of the country. I sincerely welcome him to this program, and we are indeed honored to have you here, sir, for this Ayurveda seminar. Now it is turn to welcome Dr. Mohammad Hanish, Sri Mohammad Hanish, Principal Secretary Industries. I know him very closely, and I have even worked with him for the last 6-7 years, and I've always found him to be very understanding and very supportive. He is a dear friend of Ayurveda Sala, like he's a friend of very many people, and he has a special attachment to us because he started his career as a sub-collector of Peridhalmanna. I welcome him to this program. Welcome, sir. I also welcome Dr. Praveen, who is the author of New Trends in Panchakarma. I take this opportunity in welcoming Dr. Lekha, who is the superintendent of this hospital. And I also welcome all speakers who have assembled here, Dr. Samir Ali Paravat, Dr. Jiku Benny, Dr. Nishan Narayan, and all AVS employees, and all invited guests, and all dignitaries who have assembled here, accepting our invitation. Jai Hind. Thank you.
Thank you, sir. Dr. P.M. Warrior, sir, Managing Trustee and Chief Physician, Ayurveda Shala Kottakkal, will now be delivering the presidential address. Sir, please.
Chief guest of today's function, Vaidya Rajesh Kotecha-ji, Sri APM Mohammed Harish IAS, Principal Secretary Industries, Sri Hari Kumar, Dr. Lekha, Dr. Samir Ali Paravat, Dr. Jiku Elias Benny, Dr. Nishan Narayanan, and Dr. Sri Kumar, and other dignitaries on the stage and off the stage. A very good morning to all of you. Today marks a significant day in the timeline of Ayurveda Shala. This year's annual Ayurveda Seminar is held in connection with the centenary celebrations of our charitable hospital. It is to express the deepest form of respect and gratefulness to our founder, Vaidyaratnam P.S. Warrior, whose colossal heart had a special place in the charitable hospital, that we are holding the annual seminar in the same hospital premises, paying obeisance to the luminous soul and spirit that leads us the way. Vaidyaratnam P.S. Warrior, literally the gem of a physician, started his journey in his humble and exemplary ways by first setting up a clinic in the small village of Kottakkal to serve the ailing class of society. His magnificent vision did not just confine to treating people, but extended for beyond the boundaries of the thoughts and ideas that a normal practitioner could have at that era. It was his exceptional proportion to render prepared Ayurvedic medicines in a ready-to-use and easy-to-store manner that changed the direction of stride of indigenous medicine. This indeed was a revolutionary step towards industrialization of manufacturing Ayurvedic medicine. The inspirational story of P.S. Warrior starts from that point, the first step behind which lies sub-stories about his life as a student, an ardent learner and a seeker who went through quite a lot of sufferings and struggles. The sad plight and sorrows prevailed in the society evoked the savior in P.S. Warrior, which eventually materialized as Ayurveda Shala, especially the charitable hospital. Ever since the embarkment of his journey, as a physician and a person who prioritized humanity above everything, Vaidyaratnam kept his convictions and affirmations about virtues and righteousness high, which reflected in all his thoughts, words, and deeds. I would say charitable hospital is his generosity, kindness, and his love for people embodied. An abode of altruism, and benevolence. In other words, right from the inception, this place has been serving not only as a hospital, but even as a hospice to sick people, especially the underprivileged. Ayurveda will ever remain committed to stand to the will and vision of our founder on the path of service to humankind. The centenary year of charitable hospital is a significant occasion for us to take vows to rectitude once again. Right from the beginning, annual seminars of Ayurveda have always been vibrant platforms witnessing exchange of ideas and dissemination of information relevant to academia, clinics, research, prospects as well. The seminars of yesteryears made it a point to speak of topics with contemporary relevance, with comprehensiveness and brevity. AVS K at 61 theme, avascular necrosis. It is the increasing number of cases of avascular necrosis seen, especially as an offshoot of the COVID, that prompted us to fix as the subject for this year's seminar. There was a strong feeling to count on the facts and to ponder on the potentials of medicine in dealing with this disease. We have the honor of having Vaidya Rajesh Kotechaji as our chief guest today to inaugurate the event. An academician, an administrator, a policy maker, a clinician par excellence, like Vaidya Rajesh Kotechaji inaugurating the event adds glory to it. Distinguished presence of Sri Mohammad Hanish IAS immensely graces the occasion. We are glad to bring Master Hand Dr. Samir Ali Parvat HOD, Sri Senior Consultant, Arthroplasty, Maitra Hospital, Kozhikode, a resource person for the seminar. Dr. Jikku Elias Benny is also a physician who has already proved his mettle in the area of orthopedic and surgery. Dr. Nishant Narayan would represent Ayurveda in this platform. All the more, we are happy to have Dr. T. Srikumar, an eminent academician and practitioner in the field of Ayurveda, as the moderator of the technical session. He has been a part of our events for many years and needs no introduction for this audience. I earnestly hope that this seminar would open the doors to vast scientific information on the topic. I earnestly hope that this seminar would open the doors to the vast scientific information on the topic, that our understanding and insights are widened and deepened. Ultimately, it would aid in developing more effective ways of learning and medical practice as well. It is then the purpose of the seminar would be meaningfully served. Thank you. Thank you very much.
Thank you, sir. It is our privilege to invite Honorable Secretary, Ministry of Ayush, Government of India, Padma Shri Vaidya Rajesh Kotechaji to inaugurate the event, lighting the lamp and to address the gathering. Sir, please.
President of today's event, Dr. P.M. Warrior ji, Sri APM Mohammad Hanish ji, Principal Secretary to Government of Kerala, and holding the charge of industry. Earlier he was the leader in successful implementation of National Ayush Mission in Kerala. Also, Sri K. Harikumar ji, Dr. K. Lekha ji, esteemed speakers, experts, practitioners, dear students, my namaskaram to all of you this morning, and we are assembled here for a very important topic of avascular necrosis. We all know that incidence of this condition has increased manifold after COVID, because in COVID patients got a lot of exposure to cortisone, and we all know that one of the very visible side effect is having this clinical condition. So my compliments for choosing this topic. It's very important and significant also that we are assembled here, the experts of all the different specializations, Ayurveda, different specialties of modern medical science, and we are sitting together, talking together. And that is a very good sign of, that we are all committed to the good of the people, good of the patient, and that should be the ultimate goal. This is what universal health coverage goals says to us, that no matter what path you adopt, a person should be healed, and without paying anything, and with all respect and with best expertise. And fortunately, I am standing at the premises of this hospital, charitable hospital, who is completing 100 years. And that is one of the benchmark, how universal health coverage can be extended. 160-bed hospital, and running it for 100 years for free to everybody who is coming in is not a simple thing, it's not a small thing. I want to compliment the Ayurveda Sala Parivar, starting from the legacy of Dr. P.S. Warrior, then Dr. P.K. Warrior, and now this legacy is being carried forward by Dr. P.M. Warrior and all the trustees of Ayurveda Sala. So my compliments, please. When we talk about integration, there is a confusion. Integration do not simply mean that an Ayurvedic practitioner prescribes allopathic medicine and allopathic doctor prescribes Ayurvedic medicine. It's oversimplification of integration. And that is creating a lot of confusion. So let me explain what is integration. Integration is that we all sit together, the best practices of all, we integrate with each other, and patients is benefited. Just say, for example, the avascular necrosis, and then, I was very happy to see the participants. For example, Dr. Samir, whose book is going to be released today, he will be talking about current concepts of avascular necrosis. He is an head of the department and consultant at arthroplasty and arthroscopy, Maitra Hospital. So his perspective, you can see that. Then Dr. Beni will be talking about Ayurvedic management of avascular necrosis, followed by Dr. Nishant Narayan talking will be, he is a chief medical officer at Ayurveda Sala, his clinical experiences he will be sharing. You can see that kind of, different perspective, different expertise are coming together and then talking about one single goal, how we can contribute. There is an example that in Kerala, Kasargod, there is a Hospital of IAD, Integrative Care of Dermatology. And this team, they are working in morbidity management of lymphatic filariasis, lymphedema. We all know this, it's known as hathi pav also. So patients get big lymphatic inflammation. And once it happens, there is no cure. We have to do morbidity management. And this Ayurveda yoga integration into that is creating wonderful results. There is a lot of publications and lot of practice of this morbidity management. To the extent that Government of India has decided to work with this team, implement in National Ayush Mission. Even Bill and Melinda Gates Foundation got attention to it, and now they are trying to implement it into African countries. So that is the kind of, in education. For example, in National Ayush Mission, I was just appraising the Industry Secretary, Sri Mohammad Danish ji. And at this point, I want to reiterate what Dr. Warrior ji said. He is not only friend of Ayurveda Sala, but so many others. So actually, he is a Sarva Mitra. So he is friend of all. So in National Ayush Mission, it started in 2014 with just a budgetary allocation of 79 crore. This year, it has budget of 1,200 crore. And proposal is for the next year. Tomorrow only we will be having discussion with expenditure secretary for the next year's budget. And we are proposing 1,800 crore. From 79 to 1,800 crore. And all of these activities are very effectively implemented on the ground. For example, out of allocated 12,500 health and wellness center, already 12,200 is operational. Yesterday I visited a center near Kottakkal and I was very impressed. A small Ayushman Arogya Mandir, small sub-center is catering 100 plus patients every day. So that is kind of implementation. Last year, 100 million patients, 100 million, 10 crore plus. That is kind of impact of National Ayush Mission. And there are a lot of innovative things like Karunya, like palliative care and elderly care, Vayomitra, or school health program. So this is kind of a great example how mainstreaming of Ayush can contribute into the public health, and with the help of the mainstream medical system also, because in India we have more than 10,000 co-located facilities where Ayush doctors are working together with allopathy doctors in a PHC or CHC or district hospitals. So that is the kind of an example when we all look forward for more and more such achievements. As I mentioned that in education also, National Commission of Indian Medicine, which is established in 2020, or National Commission of Homeopathy, together they are regulating more than 800 colleges across the country. And all of us are witnessing the kind of transparency, quality of education has been achieved and ensured. At this juncture, I want to compliment the VPSV Ayurveda College for achieving third rank across the country. My dear friend, Professor C.V. Jaidevan, he just passed away yesterday, the day before yesterday. We studied together in Jamnagar, and it is a great loss to the country and to the fraternity, Ayurveda fraternity. It is not only local, but globally also, the Government of India has a great imprint in the traditional medicine sector. For example, establishment of Global Traditional Medicine Center of WHO in India. Did you know that this is a WHO center, a UN office established in India at Jamnagar? And this is the first UN outpost which is established in any developing country across the globe. So that is the kind of an imprint. We have also contributed in WHO Global Medicine Strategy for 2025 to 2034. Last year, as a G20 co-branded event, we have organized Global Traditional Medicine Summit at Gandhinagar, Gujarat. And there was a consensus among 80 plus countries for a Gujarat declaration in traditional medicine across the globe. So this is the kind of contribution we are now providing leadership in the traditional medicine area across the globe. In the area of research, Government of India, Ministry of Ayush is closely working with ICMR for high impact researches. So we have a lot of COE with ICMR. We have Advanced Center of Ayush ICMR, Advanced Center of Integrative Research in different aims. For example, in Delhi aims, we have Integrative Center in Gastrointestinal Disorders and Women and Child Disorders. At AIMS Jodhpur is dedicated to geriatric health. AIMS Nagpur is dedicated to cancer care. AIMS Rishikesh for another center for geriatric care. And these centers are created to have high impact clinical studies and basic studies, mechanistic studies for the principles and practices of Ayurveda. It's not only drug research, but research on therapeutic treatments also, research on panchakarma or different therapeutic interventions. So it's like a 360-degree research centers. I also want to mention that with Government of India has recently agreed to provide a COE, Center of Excellence, to our charitable hospital for cancer care. I have just visited this cancer care OPD. And my compliments to cater more than 60 to 70 patients every day coming from across the country for integrative cancer care at this hospital. So this is kind of a benchmark which is being happened. Another example is that our country is suffering with or having a problem statement of finding a right solution for anemia. In anemia control program, we are providing iron and folic acid for few decades, but anemia is still there. Anemia is not being effectively controlled because of so many reasons. It's not only, I don't say that the iron folic acid is not effective, but reluctance of people to take it because it's palatability or its after effect as a constipation, etc. People are having hesitation of taking that solution. So we should have an alternative solution which is easy and as effective as an iron control. So Ayush and ICMR has started a large-scale multi-center trial on Punanavadi Mandur and Drakshabalehe on several medical colleges. It is already going on. And we have proof of concept that it works. But proof of concept is on small sample size. So it's a phase 3 study which is going on. Parallelly, Ministry of Ayush and Ministry of Women and Child Development came together and in Mission Utkarsh district, the same candidates are being given to 500,000 adolescent girls for their anemia. So large-scale observation study, at the same time multi-centered double-blind placebo control trial is going on. So let's hope that we will find some solution for anemia in our country through this approach of integrative care. Our Honorable Prime Minister always mentions when he speaks about Ayurveda or traditional medicine or yoga, he always mentions in his different speeches in Man Ki Baat, he repeatedly given us a direction that contemporary science should be taken help from Ayurveda people and scientists so that large scale evidences are generated. So this is taken as this guidance of the Prime Minister is taken in its spirit, and we are having a big effort of generating evidences. And I compliment Ayurveda Sala Parivar for their contribution also in the form of large scale researches, having establishment of world-class laboratories and creating benchmarks and publication of the journals, etc. So this is kind of, is an effort of all the sector in generating large-scale evidences. Also, one of the question is that when we talk about the evidence generation, we, in Ayurveda, I am an Ayurvedic physician. A lot of us are the student or physicians from Ayurveda. What we understand and know is Karya Karan Siddhant, theory of cause and effect. So if somebody gets relief, it means this medicine effective. But in modern medicine perspective, not modern science, not modern medicine, but modern science perspective, we should know how it works. It's known as mechanism of action. So we should know how Panchakarma works, how Virechana works, how Basti Chikitsa works on neurodegenerative disorders. So we have started large-scale studies on mechanistic aspects of therapeutic intervention of Ayurveda, including Basti, including Vamana, including Shirodhara. And there are some very good results. I would like to cite just one example. And I am sure that students are more interested, but maybe they will not understand what I am telling. You know, it's a bit complicated, but still I want to cite. We are having a collaborative study with ILBS, Institute of Liver and Biliary Sciences, to know how Virechana works. We know that we go Snehanam, we do some Abhyanga and external therapeutics and Snehana with Gritapan for several days, and then we do Virechana. So a study was designed, and on volunteers who is qualifying with optimum health criteria. So if there is a little bit of deviation of liver function or cholesterol or something, these volunteers are rejected. So healthy person based on the biochemical parameters and weight and age, etc. So if somebody is obese, they are not qualified like that. So these volunteers have been registered for the study. They have been given the classical Panchakarma by beginning with Gritapana, Bahya therapies, etc. And after every Gritapana, the stools were analyzed by ILBS team on a very high-end laboratory parameters for microbiomes, their microbial colonies and metabolomics and so many other parameters. After every Gritpan, it was assessed. And at the end, when Virechana happened, after every bowel movement, it was assessed to see what is happening. And you know what has come out, because we know as a physician that Virechana works into so many clinical conditions, including Tamakasvasa, including inflammatory disorders, including the neurodegenerative disorders in Parkinson and multiple sclerosis and so on. But you know, it was difficult for us to explain to a person who understands modern science how it works. This study has given a lead how it works, because what we found that at the end of the Virechana, our gut is completely clean of the bacterial colonies, completely clean, no bacteria. It means that in laboratory you create an animal with complete flush out of microbiome. And then our Sansarjan Karma, process of Sansarjan Karma by given kanji and khichdi and peya, vilepi, all these things. It has created positive colonies of microbiome after the Panchakarma, after Virechana. It means that the inflammatory markers got reduced significantly, and this is an answer how the degenerative disorders, how autoimmune disorders, how such conditions which is difficult to treat get relief in Panchakarma therapies. So those kind of high-end researches are being done. The another example is that I would like to specifically request the students to look at Google. Please open your phone and type Ayush Research Portal. So if you type Ayush Research Portal, you can go to that web-based, cloud-based platform where you can search publications of Ayurveda and all other Ayush sciences. And all of these publications, either they are PubMed indexed, index journals or peer-reviewed journals, not in the journals which is not having reputation. And they are in number is 43,000. More than 43,000 such publications are there. What I am trying to convey is that it is said when we go to the platforms, it is said to us that you people are good, it's a very good tradition, 5,000-year-old, and yes, it works on patient, but then where are the evidences? That's the question what we face. But this is the answer of that. You know, look at that Ayush Research Portal, 43,000 publications. It's not a joke. So it means that now we have the capability to talk eye in eye and then give the reply. Yes, we have evidences and we are quite confident that this thing works. It's not a pseudoscience. And then people who mentions that this is pseudoscience, they are actually having a cryptic agenda. So if somebody replies, they just take out that reply and they just propagate. So we have to ignore such people. There are some people always, when you shine, when you deliver something, there are some critics are there. And then it means that you are doing something good. Without, if everybody appreciates you, it means that there is something wrong in your working, So there should be always a critical people having you onboarded so that you are aware that criticism is possible. And it is beauty of the democracy that in democratic country only this type of criticism is possible. So we should always invite the criticism, and that gives us chance to review what are we doing. Lastly, as I mentioned, that mechanistic study is possible only through basic sciences. So basic sciences means offshoots of or mainstream of botany, physics or chemistry. And I want to specifically address to the students that students usually face this question from the patients or from the fraternity or from, in different conferences or networking sites, that you are an Ayurvedic doctor. What you need to do is this Nadi, pulse pariksha. Why you are using the stethoscope or sphygmomanometer, or why you are using the laboratory technologies? Friends, these are the sciences. It's not invented by the modern medicine people. It is invented by basic science people. Either chemistry, biology or physics. Radiology is physics. All other investigations are mix of biochemistry or biology and chemistry. So don't hesitate to use science for your excellence, for your practice. These are the sciences meant for the use of the people. And like if I am using this microphone, it's not written in Ayurveda, but I am using it, it is a science. So if I use mobile phone, it is a science. So you don't have to hesitate. You should mention that these are the basic sciences and not the only modern medical science. Actually, all advancements, most of this advancement except clinical research is being done by basic science people. You go anywhere and you can see that lot of health researches are happening in IITs or IISc and other eminent institutions. That is why we have created a National Ayush Research Consortium. This consortium is a combination of all basic science departments of Government of India like DST, DBT, CSIR, Ayush, and also Ministry of Commerce, Ministry of DPIT, so that we look at the IPR issues of the traditional medicine. So it's very holistic approach, and I'm sure that this will have some very good yield and fruits out of it. As we stand here today, a moment in history where Ayush is increasingly recognized and respected. Let's continue to strengthen the bridges between traditional wisdom, traditional science, and modern science. So, at the end, I also want to compliment Ayurveda Salas for the commitment to integrative healthcare, and it is evident for this seminar. This is I heard that this seminar has started since '64 and started before my birth, so it is 60 years. Since 60 years it is happening, and it is a great contribution. My compliments. I extend my congratulations to all the participants, speakers, and organizers for this wonderful event, and it is happening at the 100th years of this charitable hospital. So my compliments to Ayurveda Sala Parivar for running this hospital successfully and humbly for this much, like 100 years, is something very commendable. I wish you a fruitful and enriching experience at today's seminar. My namaskaram, Jai Hind. Thank you so much.
Thank you, sir. We humbly request Padma Shri Vaidya Rajesh Kotecha ji to receive a memento from our Managing Trustee as a token of our immense gratitude to you, sir.
Thank you, sirs. Now, we have the release of the book, New Trends in Panchagama Techniques, the first prize-winning essay in the 55th Vaidyaratnam P.S. Warrior All India Thesis Competition 2023, conducted by Ayurveda. The book is authored by Dr. Praveen Balakrishnan, Research Officer, CCRAS, Ministry of Ayush, Thiruvananthapuram Unit. We humbly request Padma Shri Vaidya Rajesh Kotecha ji to release the book by handing over the first copy to Shri APM Mohammad Hanish, IAS. We invite the author of the book, Dr. Praveen Balakrishnan, also to be on the stage. Sir, please.
Thank you, sirs. We have the honor of having Shri APM Mohammad Hanish, IAS, Principal Secretary, Industries, Government of Kerala, at this event to deliver the keynote address. Sir, please.
The chief guest of the day, my good friend, Dr. Vaidya Rajesh Kotecha, Secretary, Ministry of Ayush, Government of India. The president of the meeting and all-time friend, Dr. P.M. Warrior, Managing Trustee, Kottakkal Ayurveda. My good colleague, Shri K. Harikumar, Chief Executive Officer, Ayurveda Kottakkal. Dr. K. Lekha, Superintendent, Charitable Hospital, Ayurveda Kottakkal. Dr. Praveen Balakrishnan, dignitaries of the dais, practitioners of Ayurveda, students, professors, teachers, well-minded individuals, ladies and gentlemen. Certain institutions define time, they define space, and also they create history by charting new chapters in the annals of human beings' progress. In that sense, I would state that this institution, as a tower of light, as a tower of hope, has straddled the landscape for the past 1 century and more. Today, when we come to the phase of the centenary celebrations, the great memories of the past and the extraordinary work that is being done today and the tremendous possibilities of future come together to form a great opportunity for all of us to be participating in. In the meantime, I should also remind myself of the sad departing of my good friend, colleague, Dr. Jaydevan, the other day. My respectful tributes to the departed soul. Ayush in Kerala, of course, had its beginnings much before the term Ayush itself was coined. It ultimately was the confluence of all the indigenous systems of medicines together. But even before that, decades before that, it was a way of life for centuries together, as far as the state is concerned. It spread to other parts of the country as well, and to various countries far and wide. Today we have demands, requirements coming in from my colleagues in Japan the other day. They were requesting for the initiation of Ayurveda-related activities in Japan. This has been the case with several other countries with which we had interacted in my present capacity as the Principal Secretary, Industries and Commerce. And Kerala is hosting the Global Investor Summit on 21st and 22nd of February next year, in which we would certainly invite, welcome a great deal of substantial contributions in investment from the Ayurveda and the Ayush sector. Having been the Principal Secretary of the triad of Health and Family Welfare, Medical Science, Medical Services and Ayush together, which was an unenviable task, I would say, having the allopathic doctors and the Ayurvedic doctors together in one room and discussing the same topic of medical science. That was quite a very delightful experience as far as I was concerned. But when I looked at the kind of confluence of minds that could be made, I thought perhaps that with some deal of effort, the leading institutions and organizations in the both sectors of medical sciences could sit together, discuss, collate the information, and try to dissect what can be done, what cannot be done. And also they explore the very fine subtleties and nuances with which we should shape the integration of the differing systems of medicine. It is ultimately for the goodness of the mankind. That's certainly which has to be kept in mind. Government of India of late had done tremendous service to the sector of Ayush, especially after Dr. Rajesh Kotecha took over as Secretary, Ministry of Ayush. I can very proudly state that Kerala is one of those states which had a quantum jump in terms of the central assistance. When I took over the reins of Ayush Ministry, it was 98 crores. It galloped to 178 crores, and this year it has cost 200 crores. No other state has been given this kind of a fortune, thanks to our good friend over there in New Delhi. But I would seek your indulgence further, because till last May, I was the vice chairman of the managing committee of the P.S. Warrior Memorial Ayurveda Medical College. It is in need of funds, much more than whatever is required for payment of salaries and other establishment expenses. Whatever is provided by the government and the Ayurveda Shala together may not suffice for the substantial development of this institution as a center of excellence. So today we had an informal chat in the morning during the breakfast, and I'm sure that with the formal request from our side, we should be able to certainly take up this matter in all seriousness and see to it that this place of Ayurveda, that's Kottakkal, will have a center of excellence in the form of P.S. Warrior Ayurvedic Medical College, where research, development, infrastructure, everything can grow manifold, and see to it that ultimately the gains from the Ayush sector gets quadrupled. That's precisely what we have to do. Sir, I would seek your indulgence in this regard, and based on a formal application from our side, if you can take a formal decision in New Delhi, nothing like it, I would seek your indulgence, sir. Thank you. And going on to the kind of, the traditions that have been really brought about, I can state that in many parts of the country, we practice the art of Ayurveda. Today, it calls for a greater deal of potential. Certainly, the potential for export-oriented activities is also growing. But then, standardization of the quality of drugs is an important factor which has to come in. That's why we formed a committee as well during my tenure to look into this question of standardization of the drugs, and they had actually brought in a first report in this regard. But that's not enough. We need to really combat the kind of the ill will and the kind of, the misleading campaigns and propaganda that's being carried out at least by certain responsible or the so-called responsible sections of the society as well. The government in this regard has taken the initiative, but then without the cooperation of all the stakeholders of the Ayurveda sector, we may not be able to take it forward, because ultimately it would lead only to the collapse of this glorious tradition. It's beyond the treatment, it's also about medication, it's about the kind of use of the drugs and the products across the globe. If it is to increase standardization of the quality of the drugs and also see to it that the greatest synergy between modern medicine and Ayurvedic systems has to be carried out. Let's not have such compartmentalization as far as human health and human prosperity is concerned. We need to ensure that a greater confluence of minds has to happen. That's where the Ganga, Jamuna, Saraswati meets, and we create a Triveni of sorts. This is where we have to focus on. I really hope and wish that this institution grows in stature in the years to come and ultimately becomes an extraordinary institution which has its wings all over the country, all over the world, not just in terms of the physicians that it has, not just in terms of the products that it has spawned all over, that has been sold all over, but in terms of the goodwill, in terms of the kind of goodness that has been imparted across the world as a result of the spread of the gospel of Ayurveda. India or Bharat, as the matter says, has a glorious tradition, an extraordinary civilization from which we take birth. Let's see to it that we remain true to the legacy of centuries and never squander away the wealth of the past. The wealth of the past, with the kind of realities of today, shall create the exciting possibilities for future. Let's embrace that glorious tomorrow in all its radiance and see to it that new paradigms, new dimensions, new systems and models are created. Thank you very much for inviting me to this institution wherein I started my career, in fact, literally speaking, when I used to escort all the VIPs and VVIPs. I see Dr. Indira Balachandran over here, never aged. I saw her in 1998, I see her in 2024. She remains the very same Dr. Indira Balachandran. Dr. Muralidharan remains the same. So I think age remains standstill. There is some kind of a formula, magical formula to it, which if imparted to bureaucrats like us, we would also try to be amaras in that sense. Thank you very much and wish you all the best. God bless.
Thank you so much, sir. We humbly request you to please receive a memento from our Managing Trustee as a token of our gratefulness to you, sir.
Thank you, sirs. May we invite Dr. K. Lekha Madam, Superintendent Charitable Hospital, Ayurveda Kottakkal, to propose the vote of thanks.
Pranams to honorable dignitaries on and off the dais. My colleagues and myself in Ayurveda Charitable Hospital have great gratitude and honor to host the Ask Kottakkal 61 at our premises, and that too in the centenary year of the hospital. And Dr. Rajesh Kottecha, Secretary, Ministry of Ayush, Government of India, has highlighted the importance of integration of various systems of medicine under one roof. In a small way, sir, we are doing here. We have a small modern medicine department and little big Ayurveda department, and we are working in integration when they need help. And we used to refer cases to Ayurveda, and they also seek our help in needy situations. And another thing which came into my mind is, there is a concept in modern medicine now, you sir may be knowing, it is called gut dysbiosis. In gut dysbiosis, the microflora or the bacterial flora inside the intestinal system is upset, and this can lead to chronic diseases like liver diseases, allergies, menstrual disorders, and so on. So sir was talking about that Virejana Chikitsa. I think such treatment can clear this gut dysbiosis or can improve the situation. So in a way, we can treat so many cases. So there actually integration is helpful. That's what I feel. And on behalf of the institution and myself, I express my deep gratitude to you, sir, for finding time to grace the function and inaugurate the same. And we are thankful to Shri APM Muhammad Hanish IAS, Principal Secretary, Industries, Government of India, for sparing time to attend the occasion and delivering an enlightening speech. Thank you, sir. Sorry, sir. Sorry, sir. And centenary celebration as well as the events related to AVSK 61 are ably guided by our respected and beloved Managing Trustee, Dr. P.M. Warrier, sir. I express my deep gratitude to you, sir, for the sake of formality. And we express our profound thanks to our CEO, Sir Harikumar Sir, who has been with us all through, and again for the sake of formality. And our thanks are due to the learned author of the book New Trends in Panchakarma Techniques, Dr. Praveen Balakrishnan, for giving us an opportunity to release the book on this occasion. And we appreciate all those who have artistically contributed to the creation of the photo gallery and the mural paintings, which was inaugurated yesterday evening by Dr. Rajesh Kotecha. And I thank Dr. Rajagopal for the beautiful prayer rendered by him on this occasion. And I thank KMK Sound for providing sound, light and sound. And we are grateful to our friends in the media who is present to cover the function in a befitting manner. And I express my gratitude to all my colleagues of Charitable Hospital and the institution for cooperating with us in making this function a grand success. And last but not the least, we owe a lot to all those who are present here in the occasion. And thanking all of you once again and seeking forbearance. And I conclude my words and thank you. Jai Hind.
Thank you, ma'am. The inaugural session concludes here. We will begin the technical session shortly.
Okay. Comfortable also. Fine. I didn't look it up. Not I know slide.
All the delegates are requested to please come to the venue and be seated. We are starting the session.
Codeless ആണ് അത് കുഴപ്പമില്ല ഓക്കെ മാനേജ് ചെയ്യാം കുഴപ്പമില്ല ഓക്കെ ഇത് മതി ഇത് വീട് പോലെങ്കിൽ ഇത് മതി കോഡ്ലെസ് ആണ് അതാണ് നല്ലത് കുറച്ചുകൂടെ എനിക്ക് Yeah, good morning all. First of all, let me thank Madhavarya sir and all the Kottakkal Ayurveda Shala team for being me here. Because the first, ever since we are a child, the first doctor name which echoes in our ear is none other than P.S. Varya sir. Because our grandfathers used to tell the name. Because for such and such diseases, most of the week, they will visit the Kottakkal Ayurveda Shala. And I still remember my grandfather coming with some bottles, some different names he will suggest. Later only we came to know at least the modern medicine doctor's name in our ears. And later, around 15 years back, my wife had a very bad skin allergic problems. So as we have a modern medicine, our first treatment will be a medicine. Basically, it's steroid creams, steroid medications. The disease disappeared. But unfortunately, again, 2 months is required much more than what was previously. So the savior for us was none other than Sri Krishna sir, the old dermatology department from the Kottakkal Ayurveda Shala. And later, last 1.5 years back, my mother had a back pain. So she's a back pain along with some radiculopathy to the legs. So I took an MRI. There was a mild to moderate disc with some segmental instability. So even though I'm a modern medicine doctor, I don't have anything to offer. So the same person, the Dr. Shamim, is the one which treated my mother almost 21 days of Panchakarma, all those treatment, and touch wood, she's absolutely fine. That is that amount of trust what I have in Ayurveda. And probably this the Honio hospital, the Maitra hospital, have started an Ayurvedic department in our hospital for the last 8 months. And another big centers, almost 800 crores of project, integrating modern medicine, Ayurveda, Tibetan medicine, sound therapy, and yoga therapy. That is known as the Tula is the brand name. It is in Chelambra, Kozhikode. It is going to inaugurate in March 12th by none other than the Bill Gates. So this project is going to start in March 12th. So this is the amount of belief I have in other system of medicines. And I have seen some patients come to me. So we have been waiting for your appointment for 2 months. So these patients are waiting for 2 months of a belief that whether any doctor can cure their pain or their disability. So it is the duty of any doctor to keep that hope alive. So forget all the egos, anything. As I am a modern medicine doctor, I have some knowledge about modern medicine. I don't have a right to say that other system of medicine is wrong because I have not read about it. I have not taught about it. So it's my duty to talk with other system of medicine doctors and ask whether is there any option for the treatment in your system. If it is there, if it's benefit for the patient, if, as the many other speakers said, if it gives the goodness for the mankind, you should refer the patient without keeping your ego apart. Ultimately, the humanitarian should be the lead first. So we are going with a talk, is an avascular necrosis of the hip. This is what I learned from my study, and if I came here and I'm sitting here, I have to learn from you. But because there are a lot of gray areas in modern medicine where you can offer a lot more things. So the avascular necrosis is basically, it's a simple word. There is no blood circulation. That is disruption of the blood flow. And once the blood flow is disrupted, it produces necrosis of the osteocyte or bone cells. and eventually will lead to secondary osteoarthritis. We heard that the steroid, alcohol are the major culprit for avascular necrosis. Why the avascular necrosis affect the hip? Most commonly, there are a lot of other bones, almost 206 bones are there in our body. Why the hip joint is involved in the avascular necrosis? Because the peculiarity of the blood supply. These major vessels I will show you, this is known as the retinacular arteries. These are the major arteries I will show you. This is an anterior and posterior view of the hip joint. This is the femoral artery. The femoral artery, a branch of profunda femoris artery. It causes the lateral circumflex anteriorly and the medial circumflex posteriorly. This is not a complete ring. This just forms a ring outside the capsule of the hip joint, out of which the medial circumflex femoral artery is the major blood supply giving. That is through the quadratus femoris muscle, the vessel is piercing and is giving major supply. So then forms the hip capsule. These vessels will penetrate the hip capsule and then forms what is known as the retinacular arteries. There are 3 retinacular arteries, anteriorly 1, posteriorly there are 2. Anteriorly there is an anterior retinacular artery, and posteriorly you have a postero-superior and postero-inferior retinacular artery. This posterior inferior retinacular artery has a big diameter artery. That is the most resistant artery in the hip joint. So there is a postero-superior, postero-inferior and an anterior. So there are 3 retinacular arteries. Once these retinacular arteries reaches the synovium, just then comes our part of the synovium. So these 3 retinacular arteries are extra-synovial, means it's behind the synovial membrane of the hip joint. Then just below the synovium, it forms a ring that is known as a subsynovial arterial ring. Then from here, a small lot of end arteries. End arteries means once the arteries goes, it stops there. Okay. From these subsynovial arteries, a lot of small arteries, those known as epiphyseal arteries are formed. So these epiphyseal arteries are end arteries. So whenever there is a blood flow, it stops there. Then a few branches from the foveolar artery, or otherwise known as the artery of the ligament teres. And this ligament teres artery supplies only a very small portion. I will say only 2 to 3% of the femoral head only is being supplied by obturator artery. Rest all is supplied by these branches from the profunda femoris, the anterior, the medial and lateral circumflex artery, and these retinacular arteries. So you can think about what will happen whenever there is a crack here, the blood flow is affected. So this is the digital subtraction angiography image. You can see this is actually image, not a picture. You can see the arteries are coming and stopping here. You can see a lot of vessels, lot of free spaces under the cartilage without any blood circulation. So these areas are purely depends upon the diffusion of the vessels. There is no direct arterial supply to many of the areas of the femoral head. So that is why even a small culprit, small damage to the arteries or anything which creates occlusion of the blood flow affect your femoral head most commonly. So why the reason, why the blood flow happens? The avascular necrosis can be a traumatic event. Because of the trauma it can happen, or a non-traumatic event without a trauma. So what are the traumatic causes? One is definitely the neck of femur fracture. When the fracture is there, the retinacular arteries are cut off. Then comes the hip dislocation. When the hip dislocation, all the capsule is torn off, ligament teres is torn off, again the blood flow will be affected. So this happens in the femoral neck fracture. So whenever there is a fracture here, you can see all these retinacular arteries will be cut off. So that will cut the blood supply. But what is the peculiarity of the neck? Any fracture in our body to unite, the fracture union happens from 2 sides. One from inside the bone, that is the endosteum, and from the outside the bone. Any fracture to unite from outside, the periosteum has a layer known as cambium layer of the periosteum. The cambium layer of the periosteum is absent in our neck of femur. That is why the only blood supply we have purely depends is the endosteal retinacular arteries. There is no outer periosteal layer to heal the fracture. So whenever this blood circulation is affected, no doubt at all, the blood supply to the femoral head is going to get affected. So this is a assessment. The fracture neck of femur have been divided into 4 stages. 1, 2, 3, and 4. That is the Gardner classification. You can see in one type 1 fracture, that means it's an undisplaced fracture. Just a crack. Fracture is not displaced. You can see most of the retinacular arteries are unaffected. So still the blood circulation is maintained to the head. So you don't have to worry about type 1 fractures. But once come to the type 3 and type 4 fractures, you can see most of the vessels, especially the superior retinacular artery is the most important artery. It is being affected in all type 3 and 4 type of fracture neck of femur. So the inferior retinacular arteries have relatively, as I already mentioned, have a large caliber. That is the less affected, but the most affected is the superior retinacular arteries. But unfortunately, the superior retinacular artery is the important artery giving maximum blood supply to the femoral head. So this is a systematic review of undisplaced, that is a type 1 fracture neck of femur in patient with over the age of 65. What is the rate of union as well as the rate of avascular necrosis? This study is around, this include 29 studies including 5,701 patients, and out of which 1,120 patients treated conservatively, just a rest or whatever it is. And the union rate was 68.8%, but 10.3% patients went for avascular necrosis. And 3,951 patients treated surgically with a screw fixation or whatever it is. There was a union rate is better, 92.6, and avascular necrosis slightly better once you fix it. And this is again the role of the non-operative treatment. This is around 298 patients treated, ages between 65 to 101 years, 2 to 8 years follow-up. Avascular necrosis around 4.3%, non-union is 3.7%. And most importantly, 12 to 75% patients went for a displacement when they treated conservatively. Even they were operated, 2 to 9% fracture got displaced. So what are the treatment options you have for fracture neck of femur? You can see the risk of avascular necrosis 17.3 in displaced and less than 1/3 if it is undisplaced, 6.4%. So there are 2 types of fixation. One is a dynamic hip screw fixation and another is a cancel screw fixations. The dynamic hip screw, you fix it, have a high chance for avascular necrosis, almost 22%. That almost 1/4 of the fracture you fix with the DHS when will go for a avascular necrosis, but less than half if you treat with a multiple cancel screw fixations. And avascular necrosis is more common in females regardless the type of the fracture. Whether it's a 1, 2, 3 or 4, doesn't matter. The rate of avascular necrosis is more common in females because the caliber of the blood vessels is small in females. So there is a high chance for decreased blood supply to the femoral head, especially in females. And most importantly, the females are more osteoporotic than males, because once a female attains a menopause, then the amount of bone losses is 3 times in females than in male. Suppose a female attains a menopause at the age of 50 and she reaches at the 60. That means the bone density of a 60-year-old female is like a 90-year-old male. So that is why the avascular necrosis is more common in females. And most importantly, if there's a displaced fracture and the fracture fixation is delayed more than 24 hours, the chance of avascular necrosis increases by 3-fold. So if there is a fracture neck of femur, you should take it as a semi-emergency procedure, and it's displaced, you fix it. Undisplaced, you have an option of conservative treatment or any other modality of treatment with you. And especially in the pediatric age group, should be very careful because the cartilage is very precarious. There is a very high chance for avascular necrosis, especially in pediatric age group. So the role of conservative treatment is a type 1 fracture. you can treat conservatively, but take a regular series follow-up exercise. At least once in 2 weeks, you should repeat the exercise to see whether fracture is displacing or not. And this conservative treatment have no role if the fracture is displaced. You have to fix it. Now we come to this non-traumatic causes of avascular necrosis. So the most important cause is corticosteroids. And second, alcohol abuse. Then systemic lupus erythematosus, Gaucher's disease, sickle cell disease, chemotherapeutic agents, Perthes disease in childhood, and a subset of patients, idiopathic patients. So what happens in the steroid? We are telling that steroids is a culprit for avascular necrosis. Why? So when you take a steroids, these are the fat cells. The fat cells number increases. That is why when patient taking steroids, you can see that they have a chubby face, the weight gain, because the fat cells number increases in the body. Same way, the fat cells size increases as well as the numbers also increases inside the femoral head. So there is an intracellular accumulation of fat cells. So what will happen when the fat cells increases the intraosseous pressure. The pressure inside the bone increases. So once it increases, it compresses the vasculature. So produces vascular endothelial cell damage. Once the endothelial cell damage, what is known as the Virchow's triangle starts. That is the trigger of the coagulopathy. Once the coagulopathy goes, the vascular thrombosis happens, and finally the ischemia happens, and subset of vascular necrosis. That is how the cascade goes on. So the avascular necrosis is steroid dependent. This is a dose dependent. You have a 6.7% chance of avascular necrosis if you are taking more than 2 grams of prednisolone per day. And the rate increases if you take from 10 milligram per day dose increases, you have 3.6% chance of avascular necrosis is going to high. But why all patients taking steroids are not affected with avascular necrosis? Not every patient. Some patients are taking steroids for 15, 20 years are not being. And I have replaced one of the hip of my senior doctor who took a steroid only just for 1 week. So why all steroid patients won't develop AVN? It is because the genetic polymorphism, the peculiarity of the blood supply, the canal diameter. Why all patients, even though you take a lot of non-vegetarian diet, your lifestyle is not good, they are not developing myocardial infarction. But some patients will develop heart attack at the age of 20, 25. Because it is genetic polymorphism. Your caliber of your blood vessels, the property of the endothelium is determined by your gene. So genetic polymorphism have a great role in determining the vascular necrosis. And if you have a patient taking steroid for SLE, almost 90% of the steroid patients on SLE will develop an AVN, because SLE itself will produce damage to the vessel because it is a vasculitis. Along with you take the steroids, definitely going to affect the blood vessels of the hip. So SLE patients do very bad with all sort of treatment. And now next is the alcohol. Almost 20 to 30% of the vascular necrosis patients are alcohol abusers. So what is the death? Same mechanism like a steroids. It produces intracellular triglyceride deposition. Like how the alcohol produces a fatty liver, because the fat is depositing in the liver. Same, the fat is deposited in the intracellular space and intraosseous space. Almost like what the steroid is doing, same the alcohol will do. And decreases the osteogenesis production and definitely produces the cell death. And that is the avascular necrosis. So this is the 2 common reasons, steroids and alcohol. Then rest are all almost same mechanism of action is being happen. Sickle cell disease, because the blood become thicker, the sickling produces, which produces occlusion of the blood vessels. This is how the avascular necrosis happens. So once the patient develops avascular necrosis, what are the symptoms of the patient? This is the problem. The avascular necrosis in the early stages, patient never present with a hip pain. Patient will present with the back pain. And moreover that, sometimes the back pain will radiate into the gluteal region and even the thighs. So out of, if you consult 10 doctors, 8 will say this is a radiculopathy. This is a spinal problem. So any patient with avascular necrosis usually first present with a back pain, then radiate into hip joint and then to thigh. So it's almost like a typical appearance of a L5S1 radiculopathy. So how will you differentiate? You ask the history in detail. If the patient have what is the characteristic of the radiculopathy? Patient will be much better when he or she lying down, especially when supine or turn to a side. And when patients start to get up in the early morning, she'll be okay. But once she start walking a few distance, then the pain start from the gluteal region and then it start radiating. Most importantly, the radiculopathy will radiate, definitely will radiate below the knee joint. Radiculopathy will definitely radiate below the knee joint into the calf because that is the area of L5S1 or L4, L5 disc. If the pain is confined to the proximal part, you think about two spaces. Either it's from the sacroiliac joint or it's from the hip joint. And the symptoms of the avascular necrosis hip problem, patient will feel difficulty to getting up from the bed. Because when the laying down, hip is non-weight bearing. But immediately when the patient start to weight bear on the avascular bone, she will have pain. And after she walk a few distance, the pain decreases. This is how you differentiate between the pain, the back pain due to avascular necrosis and back pain due to spinal pathology. And only a subset of patients will present with a classical hip pain. That too in a later stages. Once the fracture collapses, arthritis develops. So what is the symptoms or signs of the patients? Definitely the patient come with a limping. And then limitation of the early limitation, the first moment which limits is the limitation of abduction, abduction, abduction and internal rotations. Then on examination, you will have a differential limitation of rotation. Differential limitation of rotation means you see the hip rotations. When the patient is lying supine, flex the hip, do an internal external rotations. That is a hip rotation inflection. Then ask the patient to lying prone. Then do the rotation. That means hip is in extension. Normally, normal hip joint will have a more rotation in extension because the hip is open. When you flex, hip joint closes, though you will have a less rotations. But when the patient develops avascular necrosis, the avascular necrosis area which affects is the weight-bearing dome of the hip. So the patient will have a less rotation in extension than in flexion. And that to happen when the head is collapsed. That's not for sign in early stages, that is in advanced stages. And finally, patient will have a flexion, adduction and external rotation deformity and limb length shortening. So this is symptoms and signs. Now you have to classify any disease. The treatment desired Yeah. So any treatment decided by the, you should have some classification system. So type 1 disease, there are many classification systems for avascular necrosis, but this is much more easier. That is known as Steenberg classifications. 1 means it's a normal X-ray. You can have an abnormal bone scan. Nothing won't be there in the X-ray. Patient may not have a symptoms also. And 2 means there are some cystic and sclerosis in the femoral head, especially in the weight-bearing dome. Weight-bearing is anterior, superior, and lateral aspect of the femoral head. Then comes the next stage, the subchondral bone collapses. And the 4th stage, once it collapses, the femoral head flattens out. And 5 means joint space is narrowed with or without acetabular changes. And type 6 means is an advanced arthritis. And each stage is again divided into A means mild, less than 15% of the head involvement. B means 15 to 30% of the healthy involvement, that is moderate, and severe means more than 30%. So you have one abnormal X-ray, normal X-ray, abnormal MRI or bone scan, 2 cystic changes, 3 collapse, 4 flattening, 5 joint space narrowing, and 6 advanced arthritis. So this is 2. You can see there are a lot of subchondral cysts and subchondral sclerosis. And 3 means subchondral fracture, 4 means the head collapses. So look at the little more. You can see this is a type 2. Almost very carefully you look at the X-ray, you can see some slight whitish areas, hyperintense areas. And MRI, you will definitely have a geographical lighting area. You look at the geographical lighting area, this area is covered by a black shadow. That is a fibrous scar tissues. That is important when I tell you why it is important. Once the treatment comes, I will explain. So you look at this area. This is the histology picture. The color of this marrow is different from this space. And you can see a area. This is the fibrous tissues. These fibrous tissues will prevent the growth of the newer vessels into the avascular area, because this avascular area is like a jailhouse. Nobody can break into that. So it is almost always is expanding. No new vessels can encroach into this abnormal area because of this tight fibrous tissues which will prevent the growth of the new vessels. And type 3, you can see from this space small subchondral fracture happens. You can see there are slight spaces. In X-ray you can see a crescent line, that is known as a crescent sign. So that is the stage 3. And once come to the stage 4, you can see the cartilage got collapsed. That is a subchondral collapse. In the X-ray also it will be well evident, because in the weight bearing dome, MRI also shows there is a collapse of the femoral head. And come to the size 5, you can see the joint space is narrowed, the avascular area is much more extensive, and type 6 is advanced arthritis. So once come to the treatment, what is the role of conservative treatment? Stage 0 and stage 1, you can try a conservative treatment. Or patient have an advanced osteoarthritis, but patient is not ready for the total hip replacement for time being. But what all you have to do? You should have a crutch mobilization so that patient weight can be transferred to other side, so the less weight on the affected side will give them more life to your hip joint. And you have to strengthen the hip joint, especially the hip abductor, gluteus medius, hip extensors, and especially the core muscles, the back muscles have to be strengthened. Then gentle home-based stretching exercises and spine lateral bending exercise, because once the patient have developed a hip problem, he will try to lean towards one side. So that will produce some amount of scoliotic deformity into the spine. So you have to correct the spinal deformity, otherwise once the advanced stage develop, if you correct the hip problem, patient will remain with the back issues. So what are the pharmacological treatment in the modern medicine? This is a very gray area. You don't have because there are hundreds of medications being recommended for avascular necrosis treating the hip. Why there is hundreds of medications? Because no one is successful. If you have only one successful medicine, that's enough. Why the hundreds of medications? Same way for any disease, there are hundreds of surgery, means no one is 100% successful. That is why there are hundreds of medications for avascular necrosis in the modern medicine, because none of them have proven to be benefit. But still, for the sake I have to tell you, there is a bisphosphonate, theoretically inhibit the osteoblastic activity, useful in osteoporosis, and might be useful in stage 2-3 disease, because patient come to you, you have to offer something, that's all. And you have a mixed results in the literature. Then comes the statins, because we see that the steroids and alcohol produces more fat deposition. So theoretically you give statins, can reduce the fat deposition. Still no conclusive data. And there are some vasodilators, elaprost, early stages still have a subjective improvement, because elaprost is like costly. Patient is spending thousands of money, so he should feel that okay, I'm spending some money. And then 4 is NSAIDs for the sake of symptomatic relief. So this is a gray area. I am really looking from your perspective in this sort of patients, how you can help these patients, especially when this modern medicine have a gray area. Now we come to the surgical treatment. What are the surgical options you will have? Okay, now come to the surgical management. The most common surgical management here is the early stages is a core decompression. What is a core decompression? I told you that whenever there is an avascular area, this area is surrounded by a thick fibrous tissues that will prevent the growth of the new blood vessels into the affected area. So under the X-ray guidance, we put a guide where we will make a small tunnel here and we will curate out the avascular bone. So from this normal area, supposed to develop new blood vessels into this area. Once the new blood vessels grows, it can produce a little more better bone in the avascular area. That's the core decompression, and it's useful up to stage 2A, and most importantly, it reduces the night pain because there is a huge intra-osseous pressure. Once you make some drill holes, the blood bed comes out, the intra-osseous pressure decreases, and patient will get a symptomatic relief, especially in the night pain. But importantly, SLE patients do very bad even with this treatment. Now another option is a core decompression plus non-vascularized fibula graft. Initially in the core decompression, just curate out the bad bone. You are expecting that the blood vessel will go and that will produce some new bone. Instead, you drill the bone, you curate out the bone, and you put your fibula, a piece of the fibula almost 7 or 8 centimeter, and you just tuck into this defect so that will produce how the pillar works for this pandal. It will give us support to the subchondral bone. It will prevent the collapse of the subchondral bone. Just to prevent the collapse, no new bone is formed. So provide the axial support useful up to stage 2B. Yeah, now next option is the core decompression plus vascularized fibula grafting. What you will do, these are our own cases, you take the fibula with the peroneal arteries, a part of the peroneal artery, and you expose the hip joint. This is what the blue is ties the lateral circumflex femoral artery, and this peroneal artery will be anastomosed to this lateral circumflex femoral artery, and same way you curate out of the bone, you fix the fibula into this and do a lot of anastomosis. So this fibula will give you, the new bone formation will give you, this fibula will start to unite with this bone, and that will prevent the subchondral collapse. And now a recent one, that is a more of a stem cell therapy, is being introduced with almost a good results, because the other procedure which I mentioned is a vascular fibula graft is a very morbid procedure. You have to put a pull incision here, you have to put a big incision in the thigh, and you have to do a anastomosis. You need a help of a plastic surgeon, and it's a long procedure, almost take 2 to 3 hours of the procedure. And this is a procedure, it's a 2-stage procedure. First stage, you have to take out 36 ml of marrow. You have to, like how you take the bone marrow from the posterior iliac spine, 30 ml of bone marrow is being aspirated, and that's sent for the culture. And after 20 to 30 days from the stem cells, if they make 48 millions of osteoblasts have to be formed from the stem cells, because the total amount of osteoblast in the femoral head is 48 million. So from 48 to 49 millions of femoral osteoblasts are being cultivated from the stem cells. Once it is done, it will take almost 20 to 30 days. Once the number reaches, they will bring it as a sterile pack with a maintain the cold chains. Once it is done, so same way under radiological guidance, you can see different angle curates are coming out. We curate the areas where the bad bone is there. The X-ray, under the X-ray guidance, you can see all areas the dead necrotic bone is curated out. So 10 degree, 20 degree, 30 degree angle curates are available. So whatever area is there, we just keep on curating till the dead sclerotic bone disappears. Once the sclerotic bone is removed completely, then the stem cell will harvest mixed with fibrin and thrombin. Fibrin and thrombin is a coagulant. The fibrin and thrombin along with the stem cells, this is come in the two syringes, will mix together, and that will inject through a needle into the space, and that the curated areas, and that the area is being occluded by gelatin forms, so that the tissues which we injected into the space won't come out. And in 5 minutes, because there is a fibrin and thrombin, is being coagulated and forms a solid mass. This what is known as os grow, and thus giving a lot of promising results, especially in stage 3, up to stage 3 of avascular necrosis. So but what we'll do in an advanced osteoarthritis, when stage 4, we can't offer anything. So you ask the patient the following questions. Is the pain or stiffness affect your activities of daily living? Have you tried a conservative treatment, or have you tried other modalities of treatment? Do you have a limb length issues? Is your age is more than 20 years? If the answer for all the 4 questions is yes, then the option will be the total hip replacement. But when you suggest a total hip replacement to any patients, these are some of the comments you will hear. You prolong the total hip replacement till you become age of 50. And Mr. X told me that Miss Y, some friend have done a THR long back and he or she is not walking, so don't do a THR. These are some of the questions or comments you will hear from the patient itself when you offer a THR. It's slightly true, because this is a total hip replacement after 10 years. You can see some amount of trochanter got lysed off. 18 years again is more, and 25 years you can see almost the acetabulum is gone eroded off. So what you'll do, you have to do a revision like this with a lot of metals inside. But this is an olden era. Nowadays this is a 23-year-old female. You can see the implant which is being used at that time, and this is known as a trilog stem. This is like this stem have a porous coat. This pores is known as a tantalum pores. Tantalum as a chemical or a structure which has a similar property as of a bone marrow. So the bone will grow into this implant. So that these type of implants, and this another stem known as estrom stem, so these type of stems is going to last for 30 to 40 years. So previously the old cemented total hip replacement is going to last 15 to 20 years, but nowadays these ultra modern stems is lasting for 30 to 40 years. And look at this, at 25 years if you have a cycle, you can do all these circus. At 55 years, cycle is for you for this, but at 75 years is just a dog for you to keep on walking. So you think about your quality of life, you have to spend at 25 to 55 and 55 to 55. If you develop an advanced arthritis at age of 25 and you are using a crutch and you dream like at age of 55, I can do all jugaad with the cycle. It's not possible. You have to consider your age. If you are not walking properly, your bone density decreases. So you think about the quality of life, you have to spend 25 to 55 because ultra modern implants will help you. But then comes the complications. Definitely the total hip replacement have complications. Dislocations, fractures, periprosthetic fractures, cup migrations, all are dreaded complications, definitely. The dislocation is 3.1%, readmission is 4.6%, pulmonary embolism 0.9%, wound infection 0.2%, mortality 1%. But this is important. These are the statistics of road traffic accident in our country. So when you go through the literature, a total number of 461,312 road accidents have been reported by police department in our country in 2022 years. But you overall look, THR is safer than driving in our roads. So thank you so much for being me. I hope I didn't get bored.
Thank you so much, sir. We request you to please receive a memento from our managing trustee to express our regard and gratitude to you, sir. Thank you, sirs. The volunteers are requested to collect the questions regarding each session from the audience immediately after the topic presentation. The questions will be addressed later during the discussion session. We request the audience to pass on the questions to the volunteers. Who comes to you, please? The next speaker will be Dr. Jikku Elias Benny, Chief Consultant, Orthopedic and Proctology, Vettukatil Ayurveda Hospital, Muvattupuzha. Dr. Jikku also serves as a Senior Consultant at Vempalli Ayurvedic Hospital, Thodupuzha. Dr. Jikku will speak on Ayurvedic management of avascular necrosis. He completed his BAMS from Government Ayurveda College, Tripunithura, and passed MS in Shalyatantra from the same college with a glorious university first rank in the subject. His areas of expertise include conservative management of acute injuries, fractures, dislocations, sprains, and other musculoskeletal rehabilitations, management of anorectal disorders, and other parasurgical procedures. He is also known for his oratory and literary skills with a good number of lectures and publications in indexed journals to his credit. His book, Clinical Orthopedics in Ayurveda, is well received by the Ayurvedic fraternity. We welcome Dr. Jikku Elias Benny to the session.
Namaste. Good morning, one and all. I would like to express my gratitude to Kottakkal Ayurveda for this great opportunity and heartfelt condolences to G.S. Raju sir and Jayadevan sir. Let me ask you a question. Whether avascular necrosis has any connection with evolution? And just look at this video. it's possible to see limping. In this patient, left hip is affected. There is shortening. Along with that, it is possible to see limping. When I started my preparation of avascular necrosis, I have some doubts regarding these issues, whether avascular necrosis of hip has any connection with evolution of human mankind and how the disease evolves into this particular situation. And why hip joint is prone. Now we have a clarity regarding why the hip joint is affected by semi-release recession. And whether it is to be considered only as a degenerative situation or whether there is any other pathology like Rakta Vardavada Prakopa or Gambhira Vada Rakta to this particular disease. And what is our role? What is our prognosis in this particular situation? Whether we need to consider age, comorbidities, etc. while considering the prognosis of this disease. And what is the role of bandage? As we all know, Bandhana is Sandhi Stairya Karanam. And what is the role of bandage in the initial phase? Whether avian hip responds to external Sneha Sweda, definitely, and why it is responding good. Whether there is any recurrence after 3 months or 1 year. Do we need to continue the same protocol yearly? And whether there is any better outcome like Snehana, Shodhana, Vasti, Rasayana and rehabilitation, which is giving better outcome. Whether tailor-made or customized approach needed in this particular situation. After this presentation, I hope these questions, these problems must be answered. Before starting this session, I would like to pay homage to our Guru, Padma Bhushanam, Vaidya Bhushanam, Raghavan Tirunelpad sir, and I need to convey the message. If we need to do ethical practice, we must be scientific in terms of Ayurveda. We should explain the scientific reason why we get result in this particular case, why we doesn't get result in this particular case. And I thank my previous speaker, Samir Ali sir. Sir's first slide was regarding the humanitarian concept. And we should stand on behalf of patients' care. And I thank sir for this message. And regarding avascular necrosis, definitely our message is do no harm. And second thing, Srudad Anyatra Sandushtam Tatraivacha Kuduhali. It is the sloga from Ashtanga Sangraha in Saturta. Be contented with everything except knowledge. So we should not be contented regarding our diagnosis. We should not be contented regarding our management protocol. We should evolve, refine, and as per years, as per cases, we should refine and evolve, and that is the message regarding avascular necrosis of hip. This is the basic anatomy, as some first year students may be here to attend this class, and regarding applied anatomy and the understanding of pathology, it was clearly explained by the previous speaker. And coming to hip approach, I would like to tell you a single point where we can apply LEBA in the initial stage. In the initial stage, if we need to apply LEBA, because LEBA, Parishega and Avagaha is the management protocol for Uttana Vadarakta. So in the initial stage, in between the ASIS and PB symphysis, there is a midway point. Just 2 centimeter lateral and distal, we get the access to hip because all other areas covered. If we need to do a Jaluga, Jaluga should be done 10 to 15 to that particular area. And definitely the microvascular circulation will improve in multiple sittings. It was a study conducted by my senior under the guidance of Sudhikumar sir. So definitely the microvascular circulation improves. So we can maintain the circulation. We can maintain, preserve the circulation with multiple sittings. So we should focus on this particular area. So I mentioned the area which we should apply LEBA or Jaluga. So we get access to that particular area. Regarding etiology, definitely we can divide it into 3: traumatic, non-traumatic and idiopathic, which was explained in detail. And regarding epidemiology, male to female ratio is 5:1, in between 3:1 to 8:1. And the average age is 33 to 38, but the mean age group is around 50. And bilateral hip is affected more commonly in non-traumatic situations. Non-traumatic situations. Coming to the clinical presentation, definitely there will be a pain radiating from the groin towards the medial side of knee. Sometimes the patient presents with medial side knee pain. Sometimes we need to differentiate. Regarding radiculopathy, there will be a sharp shooting electric shock like pain radiating towards the affected dermatome, which aggravates on exertion and relieves on rest. So it is the typical differentiating feature. And the most important clinical examination to be done, the internal rotation of hip is affected in prone position. You can do this particular clinical examination. You can see in this video, the internal rotation of the hip is affected in prone position. Apart from the supine position, while we do the flexion and internal rotation, apart from that, in the internal rotation, we can compare both the sides. The normal is 35 degree. So definitely we can diagnose it in the early stage itself. When the patient complains of groin pain, definitely do this clinical examination to diagnose it in an early stage, because the application of Shatkriya Kalam, if we diagnose the case before the Vyakti Bhava, in the Sanjaya stage, definitely we have a role to preserve, to prevent. So early diagnosis is must, and use this clinical examination, which is very simple. Within 10 to 15 seconds, we can come to the conclusion. And this is the internal rotation of hip in prone position. The second one is the external rotation of hip in prone position. And regarding the range of motion, we can check more commonly extension, abduction, internal rotation. Internal rotation is the most affected in avascular necrosis. So this is the flexion with knee flexion. When we are doing only hip flexion, there will be 90 degree flexion. When we do hip flexion along with knee flexion, the degree is different. 120 to 140 is the normal. This is the extension in prone position. Extension can be done in standing position also. Adduction and abduction. So just do this clinical examination. This is the first one is the internal rotation of hip joint in supine position. Second one is the external rotation of hip in supine position. This is in the sitting position. Sitting position, we can again check the rotation. The first one is internal rotation and second one is the external rotation. This is in supine position and prone position. And coming to the clinical examination, Faber, flexion, abduction and external rotation will definitely be arrested when we compare both the sides. And regarding clinical examination, as we all know, look, feel, move, inspection, palpation and range of motion. So regarding orthopedic clinical examination, definitely compare the normal side and definitely we can feel the difference. Regarding the differential diagnosis, inflammatory synovitis is one of the commonest differential diagnosis to be ruled out. In the order, osteoarthritis, soft tissue trauma or rheumatism, osteoporosis, neoplasia and osteomyelitis. And regarding inflammatory cyanosis, which is also common in young age group males in between 5 to 10, right hip is more commonly affected. Previously, there is a chance of respiratory tract infection 2 weeks or 4 weeks back. And in soft tissue rheumatism, the most commonest one is graded trochanteritis or gluteal medial tendinitis, which we can effectively diagnose with simple clinical examination methods. So coming to the third case, it was a male patient, 34-year-old, came to me with groin pain. With the clinical examination, which I explained with internal rotation of hip in prone position, it was diagnosed, but the X-ray was normal. It was in the initial phase. So for confirmation, as he was a medical professional, for confirmation, we go with MRI. MRI definitely with high sensitivity diagnosed the case in the initial phase itself. So it was diagnosed as AVN, but as he was a medical professional, he went to core decompression. He was not confident to be with Ayurvedic management. And after core decompression of 8 months period, again he came back for management with recurrence of pain. So when compared to the cost effectiveness of that particular management, definitely we can help in this particular situation. Tell our prognosis to patient in his own terms, and then the patient should decide what to follow. And for our assessment criteria, because after assessment on taking X-ray, we can see only we can preserve the same stage. In after 3 years or 4 years, we can preserve the same stage. So when we use this patient-reported outcome measures, Harris hip score and hip disability, osteoarthritis outcome scores, in this particular situation, which HWS and Harris hip score, definitely with questionnaire, we can do the assessment, and if need, we can publish also. If we do this particular assessment, then we can easily publish the case, and we need publications of avascular necrosis studies. It should be done by the practitioners. Academy will do, definitely I will show a case of avascular necrosis published from All India Institute of Ayurveda, but we practitioners should do, and it is the answer for all the queries. So we can use this patient reported outcome measures. This is a case published from All India Institute. I think it was done in 2022. This case was done in All India Institute. In these particular studies, it is documented with Harris hip score. And this is the normal pelvis with both hip X-ray. Definitely we should prescribe X-ray pelvis with both hip AP view and compare both the sides. When AVN starts, definitely you can see this is a normal X-ray. The lesser trochanter will be more prominent. The lesser trochanter will be more prominent. So it starts from grade 2 only. In grade 1 there will be normal X-ray. So for high sensitivity, MRI can be taken if needed, but always rely on clinical examination for the diagnosis. This is another case. The pain radiates from the hip to the knee joint. In this cross leg test is positive, and in this X-ray shows clear signs. As we have already seen, this is the Steenberg classification, modified Ficat classification of AVN studies. And as per my experience of last 10 years, definitely I can say when the age group is younger and the age group is below 16, our prognosis is very good. Promising result, sadhya chikitsa can be provided to such patients. When the age progresses, we cannot make any changes to the asthi. The mechanical problem happened to the asthi. But we can prevent the progression, arrest the progression at that particular stage. And in the last stages, grade 3 and grade 4, when there is crescent sign and collapse, then our prognosis is not much promising. If the patient needs to continue treatment as he is not fit for total hip replacement, or if there is some financial problem, definitely we can help the patient to preserve that particular situation, to maintain the quality of life for years. This is the grading. You can see in grade 3 there is crescent sign, subchondral lucency is there. In grade 4 definitely it starts degeneration. This is the grade 3 subchondral lucency. You can definitely see it. Don't miss this in the radiological finding. This is grade 4. As I already explained regarding our prognosis, when the patient's age group is less, below 16, our prognosis is very good. Promising result will be there. The patient can maintain all the activities. So in the initial phase of treatment, in the initial phase of 1 year, 2 year, the patient should avoid repeated strain injuries, mechanical actions, exercise should be reduced. And in the later phase, when the patient's age is between 16 to 40, then our aim is Kracharasadhya treatment. We need to arrest progression. We need to preserve the same stage with maintaining the quality of life, as the patient's symptoms, pain, limping, should be reduced. To maintain the range of motion, we should provide our treatment protocol. Definitely our limitations, the last 2 stages should be explained to patient as Pratyakaya. There won't be any change in the structural or mechanical condition of asthi. We can maintain the same situation for years. Coming to understanding our Samprapti, definitely we should have a better understanding of our Samprapti, what is happening in this particular situation. Definitely it is asthi shaya, vadavriddhi, but it is the effect. The cause is vascular problem. The cause is to be addressed. Then only we can maintain the result. We can avoid recurrence. We get a better prognosis. So there is one thing is asthi shaya happened in the Kafasthana, Sandhi, one of the main Sandhi, and there is a Pakvashaya, Abana, Vayu. The area is regarding that particular sthana, and it is happening only sthaniga, not the whole body is affected. Sthaniga Raktavarda Vada Pragoba or Gambira Vada Rakta, Asti and Majja is affected. Sometimes there may be agantuja nidana like trauma. There is another nidana like nija in the ahara vihara dushti, like steroid. In steroid, what is happening? There is a severe inflammation. At once stampana is given. When at once stampana is given, definitely there will be a nidana. Severe alcohol consumption, it also causes this particular nidana. Smoking is another problem. Some are nija causes. And traumatic condition is different, agantu condition is different. When we are assessing the non-traumatic etiology, definitely we can advise the patient to stop, because their modifiable nidana are the non-traumatic causes and we can modify it. And need to address the lakshana, but definitely give importance to the cause. And regarding the understanding of dhatu, we can see Sira, Kandara, Snayu, Asti, Majja is affected. And our concept, when we come to our treatment, definitely our protocol is, the initial phase is definitely Amabhajana, because the patient has night pain. There will be Anubhashaya to external application of Thaila. When the patient starts moving, definitely there will be mono stiffness. So we need to address the Amapajana in the initial phase. The second phase is definitely Snehana. And we should do Shodhana therapy for addressing the cause, and later phase when we can come to the effect. That means Tikta Rasa, Shira, Grada, Vasti can be given after addressing the cause, and in the later phase we can opt Rasayana. Definitely when we consider Rasayana, we should consider the Dhatu. Asti and Majja should be considered. So regarding Rasayana, I will tell some examples which what I am following. Coming to the intervention, definitely as part of Koshta Shuddhi, in each and every cases we can opt Sadhyo Vamana and Sadhyo Virejana. In this condition also, in the initial phase for Koshta Shuddhi, we can opt Sadhyo Vamana and Sadhyo Virejana, and then we can go with Amabhajana. I will explain some drugs also. There are so many options we can select as per the condition of the patient. As per the condition of the patient, how the patient presents, after assessment, we can select drugs. If Snehana is not possible, sometimes Snehana is not possible in such situations, we can opt with Snehavasti. And regarding a vascular necrosis of hip, when we go through the papers, when we go through the publications, definitely we can see the importance of Vasti. When we explain the pathology on understanding the Samprapti also, definitely the main treatment is Vasti. But please remember, Tikta, Shira, Grada, Vasti is managing the Astishaya, but before that definitely we should address the cause, Raktavarda Vada Prakopa. Coming to the premium nutrition, definitely as part of Rasayana. When I say about Majja, some of you may be confused whether it's practically possible or not. But definitely we can advise soup, goat's soup. Majja is for Asti Purana. As part of nutrition, definitely Sapipeli, Sayava, Sanagara, the yoga should be taken, and we can give Majja of goat. Definitely it will help the patient at the end. The Rasayana should be given at the end. Definitely it will help. And please do remember, if we are taking Asti, then we can nourish Majja. If we are taking only meat, we can nourish Vasa. Definitely we need here Asti. Asti itself. Asti itself is to be needed for Majja. Asti Purana. Instead of non-vegetarian people, if for vegetarian, we can give Mudgayusha. We can give steam boiled banana to such patients. So there are other alternative options also. As we all know, Gandha Daila definitely helps in this particular situation. As part of premium nutrition, it can be given for 2 to 3 months. With Gandha Daila, for bioavailability, a small quantity of Pippili or Nagara should be added for the bioavailability. Very small quantity. Laksha, Maduga, Pippili can be used as Shira Kashaya, and Laksha and Maduga is taken from Chakradatta Bhaknadigara. Definitely it will help along with Gandha Daila. And Chukili Rettiyadi, Krishna Dila, Jagari and Nagara. It can also be given as Rasayana in the last phase. Coming to the Patti of Ahara and Vihara. Patti of Ahara and Vihara, definitely Lankana and Sukshma. In the Divdobakramaniya Adhyaya, the Karshana Ahara can be given to this patient to maintain the weight, to reduce the weight. A healthy weight should be maintained. That is one of the most important protocol to be maintained in the management of avascular necrosis. When there is weight gain, our prognosis will be bad. So we can opt the Ahara like that from the beginning of treatment. at the time of IP management and after IP management also, definitely the patient should be advised regarding which food is to be followed. As part of Brahmana, this puffed lotus seed is using in All India Institute for these patients, and such things also can be taken. Definitely it is help as part of Brahmana. And regarding Vihara, in the initial phase, first 2 weeks of management, definitely when we give Ama Bhajana, ask the patient to take rest, avoid weight bearing in the very initial phase for better result. So, as part of Vihara also, controlled and regulated activities, which is not causing mechanical problem to hip joint, should be advised to patient. I will explain regarding rehabilitation, how to advise rehabilitation in the coming slides. And regarding Aushadha, some of the examples of medicines in the very initial phase we can opt Pajanamrta Kashaya, Punarnamadi Kashaya, or Deshamula and Rashna Panjaka Kashaya. In the later phase, as part of Snehana, we can definitely take Gugulu Tikta. And later, when we give Tikta Shira Vasti, it can be samskaras can be done with either Danundra Kashaya Churna or Deshamula Kashaya Churna or Panjatita Kashaya Churna can be added as per the condition of the patient. In the last phase, definitely Gandhadaila, Tippali, soup, such things can be given. Coming to the concept, the Dravya Samanya concept, as we all know, we are giving Tikta Shira Vasti. Definitely we can take that for Dravya Samanya for Asti Poshana. And regarding Guna Samanya, Snigdha and Karatva. Snigdha Karatva is the Guna which is needed for the nourishment of Asti and Majja. And regarding Karma Samanya, rehabilitation. Rehabilitation is Ananaya Sweda. Isha Dushna definitely reduces the skannata of Rakta. This skannata of Rakta is definitely causing the problem in the very initial phase of setting. So definitely we should advise rehabilitation. There is another important thing regarding rehabilitation is the patient is regularly doing rehabilitation morning and evening. Then the limbic system also works. Limbic system always gives positive response. This rehabilitation is to reduce pain. This rehabilitation is to reduce disease. Definitely, likewise, the regularly doing rehabilitation helps the patient with the action of brain, with the action in pain pathway, so it helps the patient. And these corrective measures, this is very, very important. Why? Because it should be advised to patient. If we are managing avascular necrosis case, definitely when there is shortening of limb, footwear correction should be advised. It should be customized also. Or we can advise insoles. Core muscle strengthening, just giving rehabilitation to hip is not the possible way. The proximal joint, the lumbosacral joint, the distal joint, the knee joint should be considered, and always consider the contralateral hip and knee also. When we advise the rehabilitation, definitely we need to address the contralateral hip and knee to maintain the quality of life of that particular patient. And Nidana Parivarjana, as we already discussed, the Nija causes can be avoided. As the patient to reduce the trauma, repetitive strain injuries, sahasa, mechanical stress to the joint as corrective measures. Coming to rehabilitation, rehabilitation also should be discussed, because when we consider three things, one is regarding the understanding the samprapti, the management. The second thing comprises of rehabilitation, and third thing avoiding the cause, the ahara vihara patyam. So when we consider all these three things, then definitely we can give better result to patient. Coming to rehabilitation, the stage 1 and 2, in stage 1 and 2, now we all know stage 1 and 2, stage 3 and 4. In this particular situation, the range of motion preserving exercise of hip, lumbosacral spine and knee is needed. At that phase, after the range of motion exercise, we should strengthening exercise to gluteus, abductors and quadriceps. Please do remember, we should have a definitive idea regarding applied anatomy when we advise the rehabilitation. In stage 1 and 2, stretching should be given to the adductor group, hamstring, and the lumbar muscles, paraspinal muscles and quadratus lumborum. So stretching should be given to these, strengthening should be given to abductors, then extensors and knee extensors. Coming to the rehabilitation of 3 and 4, the stage 1 and 2 should be continued, but please do remember, in this stage the patient should avoid weight bearing exercise. It is better to avoid weight bearing exercise. Floor exercise will definitely be helpful. In that stage, aquatic therapy also helps. If possible, we advise aquatic therapy to patients, and in between the exercise the patient needs rest. So in this situation, definitely avoid lunges and squats. So it should be advised. It should not be done, should be advised, and knee and gluteus of normal limb also should be given rehabilitation. Coming to the yoga, as we all know, these all exercises are floor exercise. So as per condition, never advise rehabilitation before Amabhajana. It will aggravate the situation. After Amabhajana, start rehabilitation. From stage 1, 2, 3, the first stage is Mritpinda Dharanam, active use and exercise. Second phase is Levanamanda Dharanam, active use and exercise against resistance. Third phase is Pashanamanda Dharanam, active use and exercise with weight bearing. So this is the protocol to be given as per the condition of the patient. As we all know, Sedu Bandhasanam, Merudandasanam, Pavanamuktasana. Pavanamuktasana should not be given in the very initial phase. In the later phase, it should be advised. Shalabhasana, Shishuvasana, Ardha Malsendriyasana can be advised to patient based on the condition. Always please do remember, it should be customized. Hip conditioning exercise. Actually, the first one is Ardha Malsendriyasana, second one is knee chest. These exercise can also be given. Coming to the red flags. I already explained the protocol of avascular necrosis. Coming to the red flags, when to refer this patient, we should have a clear-cut idea regarding when to refer. It is based on the age, comorbidities, level of pain. Level of pain is actually subjective. It is based on the Sara and Sotha of patient. Even if the patient is not responding to conservative management for 8 to 12 weeks, then it is better to refer that particular patient, because please do remember, the patient should divide, the patient has autonomy, do explain everything in terms to patients. And the location and extent of necrosis, I already explained. If it's grade 4, when there is collapse, our prognosis is not promising. So please do remember, in these situations, we should refer the patient. We should have a good referral system for the betterment of patients and society. Definitely it will help us, our community and patients. And coming to our strength and weakness, our strength definitely includes cost-effective methods. I already explained, when compared to the cost, definitely we can give promising result with cost-effective methods. And our weakness is surgery. Our opportunity, please do remember, internal sneha, shodhana and rasayana. It definitely helps the patients, avascular necrosis patients, follow this protocol. If the patient follows this protocol, definitely the patient will be benefited. And our threat is quacks. Without knowing, they are doing external therapies, which will definitely harm our fame also. When we compare this graph, the effectiveness in the initial phase, definitely if the patient's age is low, we have good prognosis. When the patient's age is more, then it is Krachrasadhya. When the grade is 3 and 4, our prognosis is not much good, then it is definitely surgical management is needed in such situations. And the takeaway message is, treat the cause. Our goal must be realistic and prognosis must be explained to patient. This is the takeaway message of this today's session regarding avascular necrosis. Coming to the conclusion, early diagnosis is very, very important. In that thing, history also. Take time, whether there is night pain, whether the patient has morning stiffness, definitely ask and do the clinical examination. Always our diagnosis should be clinical. When the patient comes with MRI, there is grade 4, do the clinical examination, assess the patient, and whether check the radiological finding and clinical evidence are same. Based on clinical examination, we should proceed. So we should use the relevant investigation for the confirmation of diagnosis. This is a better option, better line. And coming to the specific management, I already explained. The initial phase should always be Amabhajana. Second phase, internal sneha. Third phase, Shodhana, Virejana, and Vasti can be opted. Then the phase is Tikta Upagrada, Shiragrada Vasti. Tikta Shiragrada Vasti is the main protocol. In the initial phase of Snehana, we can opt Guguladagrada. In the later phase, Panja Tiktaga or Maha Tiktaga, Panja Tiktaga Samskrita or Dhanvantara Samskrita or Deshamula Samskrita, Shira can be used for this purpose. And in the last phase, Rasayana. Last phase, Rasayana, definitely give result Gandhadaila or we can opt Mahasneha, or we can opt Majja. Also, rehabilitation should be included timely after Amabhajana. Please do consider the contralateral hip and knee when we consider the rehabilitation. This integrated approach definitely help us with maintaining our concept. And this is the message from Oliver Sacks, a world famous neurophysician who wrote so many books. We should live our life. We should find our path. Actually, there is ocean of opportunities. We need to discover our strength and design our destiny. So, we should follow our path. We should follow with our dream. Once again, thank you very much for this great opportunity. Thank you very much for the patient listening. Thank you.
Thank you, Dr. Jikku. In appreciation of your valuable presence and informative presentation, we request you to please receive a memento from our Managing Trustee. Thank you, sir. Thank you, Dr. Jikku. Next will be Dr. Nishan Narayan on the stage. Dr. Nishan Narayan, Chief Medical Officer, Ayurveda Shala Cortical, will be speaking on clinical experiences in avascular necrosis. Dr. Nishan Narayan completed his BAMS from VPSV Ayurveda College Cortical in the year 2002. Since then, he has been working with Ayurveda Shala in various capacities. He served as a branch physician at Secunderabad, Kolkata and Kottayam branches of AVS, and also worked in Ayurveda Shala Medicine Manufacturing Division for a significant period. He is presently working as Chief Medical Officer at Ayurvedic Hospital and Research Center, Cortical. For formality's sake, we welcome Dr. Nishan Narayan to the session.
Hello. Respected Managing Trustee who's backing me up today, trustees, distinguished guests, eminent physicians, fellow doctors and friends. A very good morning to all of you. It is a privilege to stand in front of you on the behalf of Ayurveda Shala to present this paper. It is an overwhelming experience for me since I am going to present about my clinical experience at a venue where I started my clinical journey 22 years ago. This was where I started my clinics. And then it is also an honor to be a part of it, as it is the 100th anniversary. These emotions are actually expected, the overwhelm, the honor, the privilege. But I also feel a sense of loss for two people who left us, Dr. Raju sir and Dr. Jaydevan sir. Jaydevan sir had been my teacher. He was a vibrant presence in all our seminars, and he's being missed today.
I'll be presenting few of my observations and inferences from few of the avascular cases amongst the hundreds of cases that are coming to Ayurveda Shala every year. Vaidya Kotecha ji today said that after COVID, that there is an increase of avascular cases. I kind of agree with him, but I do not know if that is just because of the steroids or the post-COVID scenario. It may be true that COVID has played a part, but there is another positive thing. During the COVID time, when the world was in a confused state where to go to, a lot of awareness programs were created. Even our Prime Minister had gone on to say recipes in Ayurveda. So there is a great sense of more awareness regarding the possibilities of Ayurveda, which is being explored by common people. So whenever there is no question, then there is no answer to something, they are now approaching Ayurveda as well. So that may also be a contributing factor when it comes to increase of avascular cases for us. My inferences are actually not individual ones. It has collectively evolved through discussions with my colleagues in Ayurveda Shala. We have platforms where we discuss. So let me now take you through my presentation. Basically, Dr. Samir Ali sir and Dr. Jiku Beni. So he has given a very good platform. The things have been very well explained, most of the things. I won't be touching into most of the things, but just for the sake of explaining the way these treatments were executed, I may be touching few topics as concepts also. Thank you. So I'll just go to my presentation. Praise to our presiding deity, Bhagavan Vishwambaran, and homage to our founder, Vaidyaratnam P.S. Vaidya sir, who has been a guiding force behind all the activities of Ayurveda Shala, even this seminar. Sharing of information goes a long way in propagation of science, which was a part of his vision. Before I venture into the presentation, I would start with an anecdote, which I think is relevant. This continues to inspire us, and most of us in Ayurveda Shala already know of this story. It's not a story, it is an anecdote actually. It is regarding Dr. P.K. Vaidya sir. Dr. P.K. Vaidya sir in his early 90s discovered that the his nail health was deteriorating. Being the scientist, physician he was, what he did was, he understood that Nakha and Kesha were the mala of Asti. And the Asti was situated, the Vata was situated in Asti. So doing Vatahara Chikitsa, it may be that his nail health will improve. And as we all know, the most commonest things when Vata comes to our mind is Kurundoti, that's Bala. Kurundoti ke Vadam, there's a lot of sayings like that. So he started taking powdered Kurundoti with milk for a period, and after a while, we saw his nail health improving. With this story of, or anecdote of restoration, will I begin my presentation on necrosis. Because we are thinking of something that we believe is not reversible, and we at Ayurveda Shala has been seeing reversal of a lot of things that would provide the gist of what I'm going to present. Now, for the benefit of students here, for the third time on this stage, I'm going to define avascular necrosis, a pathological condition that results from interruption to the blood supply to the bone, causing death of a bone tissue. I'm sorry, I'll take the mic now. Actually, I feel we Ayurvedic physicians have an edge over our counterparts in other medical systems. And that is, we had been having gifted writers of our texts who were imaginative enough to explain to us in a lot of imagery. Dr. Samir Ali's presentation, when I saw that in the first slide, it was so much good with imagery. And we had certain things like Kedara Kulya Nyayam to explain how the nutrition passes on to the field. So there is an obstruction to the field, and we see the bone tissue getting degenerated. So that Kedara Kulya Nyayam becomes, you can visualize that. Before I go into the presentation, for the sake of continuity and later explaining the treatments, I would just go to the basic things. The bones commonly affected in our classes, not in our classes, we were taught that these were the bones that were commonly affected: femoral head, scaphoid, talus, humeral head, radial head, humeral capitulum, lateral femoral condyle. But in clinical practice, in Ayurveda Shala, the most of the things that we faced were femoral head, humeral head, lateral femoral head. The humeral head is a recent thing because there was a case which presented itself with hip avascular necrosis. But after a year, they complained that they had some shoulder pains also, and in Delhi it was diagnosed that the lady has avascular necrosis of humeral head as well. So we can always say that it may be due to the post-COVID effects. The second thing is the concepts which will go into executing our treatments. As you know, one is the Vata, then Asti, Agni Mandhyam is there, Srodhorodham and Dhadukshayam. Vata is a dosha which is most predominant. The dhatu that is affected is naturally Asti, but other dhatus as well. Agni Mandhyam is always there. Dhatu Agni Mandhyam is what I have in mind. Srodhorodham is happening, and then later on it culminates in Dhatukshayam. So if we are to explain the Samprapti in a very short manner, it is having Dhatu Agni Mandhyam, which causes the Amam, which in turns becomes Srodhorodham, and then there is Vada Vriddhi, and finally Astikshayam. The Agni Mandhyam can be due to different causes. Dr. Jiku has already explained those things. It may be injury, it may be steroidal use, whatever that is causing Amam and causing the Srodhorodham will be causing this Vata Vriddhi. Now, if the Samprapti is that, the treatment principle is anybody's guess in Ayurveda, I should say. It is we do the Pajanam Devanam, then we go for the Srodho Shamanam, and then Vata Shamanam, and finally we go into the Rasayana part of it. The symptoms which we know of Astigata Vada, Vedo Asti Parvam, Sandhi Shulam, Mamsa Kshayam, that is, we do have certain amount of Mamsa Shosham involved. Then Aswapnam Sadada Ruk is also the symptoms that are mentioned. So when we put it into the clinical slides, for ease of planning treatment based on the symptoms, I've divided into three. That is, one is a Vada predominant, and then Pitta and Kapha would be associated, because main dosha would be Vata only. Pitta and Kapha usually provide associated symptoms which might be helpful in when we devise our treatment protocol. So, even if it is Vatam, Kapham or Pittam, basically what we will do is Vata Shamanam. And Vata Shamanam, it would be basically Brahmanam. When we say Brahmanam, it sounds a bit big, adding up to weight. So I've just added the word Poshanam, because Dhatu Poshanam would be what we would be concentrating on. Then the symptoms that go into Vata predominance, that is, chronicity would be there. It would be a chronic case. There would be pricking type of pain, loss of strength, paresthesia, and limping. These are the symptoms patients usually come to us, which we can say that it is more Vata predominant. In Pitta, which is associated, it will be mostly subacute. The patient may be of middle age, stabbing type of pain is there. Then, this is the most important part, there are signs of inflammation as well as burning sensation involved. There are certain patients who come with burning sensation. I'll explain to you in the coming, when I am going into the case presentations. The kapha associated would be restricted movement of joints. The age is usually young. The pain is not so severe. There will be some heaviness to the limbs as well. So these are the kapha associated symptoms. Now going to the cases now finally. Actually, this was a 40-year-old male, was admitted period was around 21 days. I was from Kerala, basically from Malappuram itself. He complained with pain in the hips and it was radiating to the lower limb. He had a history of 5 months ago, that before he was admitted, around 5 months ago, he had COVID. There was a vitamin D deficiency also. That is one part which I think we should be covering up, because vitamin D deficiency has to be addressed in such cases. We have to do it, because in resorptive stage of vascular necrosis and all, vitamin D does play an important role. So the kashayams that were given were Maharasnadi kashayam, Gandhadailam was given, Osticot tablets, which is Rasna Saptakam and Gugulu into it. Then Gugulu Tiktam was given in the later stages. I'm just explaining the number of medicine because I cannot explain all the cases, because there are around 8 cases or 9 cases now. So I'll be going about what all were done, but it was done as per the stages. Then in the treatment part, initial as a part of the Rukshana Kriya, we did the Podikiri, followed by Pidichil and finally Navarakiri. When we did Navarakiri, we had added Mamsam and Ashwagandha into it. The Vasti was, initially we did the Kshira Vasti, that was in the 2nd week or so. We did the Kshira Vasti initially. Matra Vasti was given too. Matra Vasti with milk and Dhanvantaram Medupagam was used. Sometimes we usually use Tiktagradam plus milk. Sometimes it is Dhanvantaram Medupagam plus milk. So after that Kshira Vasti, when we shifted to the main Vasti things, we used Kshira Vasti and then we went for Rajayapanam. Locally, Manjal Kiri was done. Manjal Kiri contains a little bit of egg, and sometimes when there is a stiffness or so, we add lemon juice into it. If there is more pain oriented, we may be using ginger juice. Then Upanaham was done. The oils which were used were Mahasneham was used, Mahamasham was used, Rasatailam was used. In certain cases, not this of course, Ketakyadi Xylem has also been found to be effective. This was a case of grade 2 avascular necrosis. The second case was a 32-year male. The admitted period here also was 21. He was from Chhattisgarh. He had pain in the right hip joint. There was a difficulty in walking, numbness in right lower limb. There was hair loss. Dhanvantaram Kashayam and Maharaja Prasarani was given here. Rasadailam was used in this case. Dhanvantaram Medupagam was milk, was used for angioplasty, this Matravasti. Grade 2 right femoral head was diagnosed. These 2 cases were also grade 2. So I have selected few cases which are grade 2 initially, because of all the cases we have to have a common kind of platform. So that is why if you notice the symptoms here, both of them are basically more Vata oriented. So the Kashayams also where Maharasnadi and such things were added initially. So these were the 2 cases. I'll come to the conclusion later. This was another case of 43-year-old male. He was admitted for a period of only 14 days. He had a history of systemic lupus, and he had COVID in 2020, typhoid in 2015, chikungunya. There was a long history of a lot of diseases. So in his case, there were a lot of gastric discomfort, so Pythika symptoms were also mentioned. So we had started with Nimbamradati, Panchadiktam and Kaisharogulu. Evening, in the morning dose, it was so, and in the evening we gave Dhanvantaram Kashayam with Rasatailam as a main body. Mahatikta Kritam and Gugulu Tiktam both were used during the course of treatment. Pravalabhasmam was added and Kurundotipadi was also given. Kurundotipadi in his case was given after the breakfast time with milk. In the treatment part, we had initially did Avanakku Ummattu Naligeram Kidi, which is a particular kidi chigil treatment which we do in Ayurveda Shala. Then for reducing his pains, we had used Dashamula Sudhakshiradhara. Pirichil Navarakiri was done as it is done commonly here. So the Kshiravasti was there. Upanaham was done. Ketakyadi Tailam and Mahasneham were used. Mahamasha Tailam was also used here. This was also a case of stage 2 avascular necrosis of femoral head. Then the other patient was a 36-year-old male. He was also admitted for 14 days. The pain in hips since 6 weeks. In his case, Guguli Tiktam Kashayam was given, Osticot was given, Gandharvastha, the Erandam was given initially. In the follow-up, we had put Kurundotipodi and Pravalabhasmam. In his particular case, after Kshiravasti, we had gone for Dipanchamula Divasti, which had given better results. When from the Vasti point of view, if we are doing, like there are certain patients who came for 3 times or something, initially we had done Kshiravasti, and if the patient is comfortable, we would usually go to Dipanchamula Divasti. In later stages, sometimes we go to Rajayapana Vasti. In this case also, it was a diagnosed case of bilateral avascular necrosis. Then comes a 52-year-old male. I was admitted for a period of 20 days. He had a pain in hips, difficulty in walking, hip movements were restricted. Actually, in 2021, he was diagnosed as avascular necrosis of femoral head. Then there was mild disc bulge also. In 2021 October, he had that, and then he went and had his core decompression and BMAC injection in the same. After a while, he still had the pain. So then he took another MRI and then came to Ayurveda Shala. In his case, when we had given Dhanvantaram Kashayam soup, which Dr. Rajiku was also explaining, but that soup could be given. So Dhanvantaram Kashayam soup was given, Dhanvantaram medicine as well as the mutton soups. So then in this particular case, we had started with Gugulitiktam, but the patient had some allergy towards that. So we had shifted it to Dadimadigratam. We had continued with that. In follow-up, we had given Dhanvantaram Koatham and Gandha Tailam to be continued for a longer period. Initially, during the course of treatment, initially he had Dhanyamaladhara. Then after that, we had gone for Dashamula Sudhakshiradhara. Kshiravasti was done. There was a stiffness part, so Pachakiri was done. So according to Avastha, we can change the treatments. It is not definitely that this protocol has to. Each day the patient will be complaining to us about a particular thing. Accordingly, we have to innovate, and the treatment protocol could be changed. Navarakiri and Upanaham was done. So the patient went with lesser pain. The pain was a bit reduced even during the treatment period. After follow-up, after 2 or 3 months, he had said that he is feeling considerable relief in his symptoms. Then comes the 60-year-old male. He was admitted for a period of 60 days. This age is also important. He had pain in groins and thighs while walking. So there was a burning sensation in the groin area, numbness in the thigh. We had started with Dhanvantaram Kashayam, Gandha Tailam, Dadimadigratam and Pravalabhasmam. Kshiravasti was done. And then in this case, we had done Rajayapana Vasti. Mahamasha Tailam was also given as Snehavasti itself. It was a grade 2 avascular necrosis. Diffuse marrow edema was seen in both femorals. Now, this is a particular case which I would draw your attention to the part, pain in the groins and thighs while walking, burning sensation in the groin area. So we know that the Asti Dhatu is affected. But if you see the burning sensation in groin area, numbness in the thigh, it is a Kshina Shukla Lakshanam. It is a Kshina Shukla Lakshanam. You will find this symptom specifically mentioned. So that was the reason why we did Rajayavana Vasti, or it was more nourishing in that sense. So after Asti, when your Asti Kshayam is happening, then the Majja is also getting affected. then it is translating into Shukla also getting affected. So that is an important part. We cannot stop at just Asti here. We have to go further to see other dhatus are also getting affected. Now, talking about the imagery which I was telling, we know that we had the Kedara Kulya Nyayam. One dhatu will be nourishing the next dhatu. So the Kedara Kulya Nyayam is there. It is a kind of dhatu parinam, right? So there is some kind of stoppage in this dhatu parinamam so that Asti dhatu is not getting properly nourished. So I would like to postulate something else. There is another imagery which I would like to show you. In economics, they have this trickling down effect. You know, you give more richer to the richest, and then it trickles down to the people below him. So the trickling down effect, if we use here, which is the richest dhatu we have? The richest dhatu would be Shuklam, because it contains the bhava of all other dhatus. It is the final one. So if we are going to replenish the Shuklam, is it possible that it will trickle down to improve the Majja and Asti as well? Would Vajikaranam be an answer or give an answer to replenishing the dhatus beneath it? Because dhatu parinama, you go from one portion to the other. If we can give some thing, like in Vajikaranam they say, Sharira Kshaya Rakshartham Vajikaranam. So there is also a Kshayam happening here. If we replenish the Shukla dhatu, it may be replenishing the other one. Now if we are going to think of that, then we have to find out what this Shuklam actually means. The Shuklam part should not be limited to just semen here. The Shuklam part may not be semen itself. Shuklam is something of the Paramadhatu, which can, of course, has the bhava of every dhatu. So I would take Dr. Samir Ali's final slides about stem cell therapy. Why don't we equate it with stem cells? Because a stem cell is something that gives rise to other cells as well. There is something called cell plasticity now. It doesn't mean that one cell will give to the same sort of cell. And if we look into it in the other manner, he was telling us about how stem cells are collected from the bone marrow. So from Majja, Shuklam is being formed. And here, the stem cells are being collected from the marrow itself. So why don't we use potentiate the stem cells? Because if we are going to potentiate the stem cells here, it may pose a good solution for our degenerative cases. We need not give the stem cells from outside. That is what the legalities were there, because when you're injecting something, there will be experimental. But if our stem cells are there and we have some ways or means to rejuvenate that, then there is a possibility that we may be able to help it. That is one of the relevant things that I wanted to point out with the story of Dr. P.K. Vairas's nails initially. Because in his early 90s, he was able to regenerate. So the stem cells are not gone. It only requires certain kind of stimulation from our part. We have medicines. For each dhatu, we will have one sort of rasayana. So those can be used here, I would like to say. So from that short break in between the case, I'll go back to the cases. This is a 31-year-old male patient whose first visit was in Jan 2024. He was admitted for a period of 14 days. He had pain in both hip joints and inguinal region, difficulty in walking, diagnosed as avascular necrosis in September 2000. Bone grafting was also done. In his case, initially we had started with Induganta Gradam because of certain symptoms which he mentioned. Then later Dhanvantaram Kashayam with Mahabala Thailam was given. Gugulu Tiktaram Gradam was said. The Gugulu Tiktaram is a very good medicine because it includes Sandhi, Masti, Ajja and all those things. So then here we had used, instead of the Kurundoti Podi and all, we had started using Asti Samharadi Churnam. It contains Changalambaranda, Asti Shankala. So the treatments were done was avascular necrosis. For that we had done AUN things, that is Avanakila Ummatila Naligram, that is a short form for, because I'm a bit lazy about typing it, so that is how I put it. So AUN means this Avanakila Ummatila Naligram. Then Pirichil was done, Navarakidi was done, Matravasti was done with Tiktagradam, and then Dvipanchamuladi Basti was there. So investigations, this was what it was there. He visited in Jan 2024, and then August he was back, because he said that both hip joint pains were not there. He was only having hip pains in the left side. His walking was better. There may be other reasons also for that, but functionally he was better. That is what I would like to tell you. Dhanvantaram Kashayam and Mahabala Thailam was given this time also, Osticart and Goguli Tiktagradam. When he came initially, that for the initial stiffness and all, we did the Avanakala Ummatala Naligaram Kidi. Manjal Kidi was done locally after application of Ketakyadi Thailam. Ketakyadi Thailam is for especially good for the asthis. Upanaham was done. Pachakidi was done additionally this time. Last time in January we did not do that, but this time we did Pachakidi also. So in the grade 2 cases, around 8 cases were there. There was pain, gait and range of movements were assessed. Most of the cases Kshiravasti was done. Then Dhanvantaram Kashayam soup was given. Navarakidi was given accordingly, that is each avastha and all. We found that there was around 30 to 40% of improvement in the pain, gait and range of movement. This patient actually, after 2 visits, a month ago he had called. He still developed some small pains, and so he is asked to come again. So the thing is, there is a kind of hope in the patient that he is getting better. So that repetition of coming that we are finding here. Now these were all the cases where grade 2 steroids were used, grade 2 steroid induced were given. I told about that Vajikarna drugs can be used. Incidentally, I just skipped my mind to tell you then. Incidentally, I found a small article where it is said that sildenafil, which is used for erectile dysfunction and all, is found to be effective in steroid-induced avascular necrosis. There are studies there. I think any of you can Google and find it out. There are plenty of them things. So I think when we are thinking of Vajikarnam and all those things, the people have already started. It said that it is revascularization and all, it helps. But it is, I think, animal studies, so I thought better not to mention it. This is a grade 3 patient, grade 3 avascular necrosis. She is a 22-year-old female student. The admitted period was 21. There was pain in hip joints, buttocks, thighs. Walking difficulty was there. She had a history of a tumor of the pituitary glands. So after that, she had developed this. She had gone and found out that she had these problems, and we started giving her Dhanvantaram Kashayam and Rasatailam, Gandhatailam, Balarishtam, and Nimbamradasam were given additionally to improve the circulation part. Pirichil was done as usual, and in the particular case, since the girl was a slightly obese sort of girl, we did not do the Navarakidi lest we make her more heavier, or we had used Ragi Kidi instead of Navarakidi. This Avanakala Ummatala Naligarakidi locally was given. So Ragi Kidi was done and Matravasti were given. And there was a pre-investigation was grade 3 avascular necrosis. And after going from here, she again had a checkup, and they said that femoral heads 80 to 90% avascular necrosis was there, right was 40 to 45%. Then the second visit, after a span of around 8 months she came, she still had the pain in hip joints. So this time we had again started with the Dhanvantaram Kashayam and Rasatailam. Guguludikthagam Gridam was continued. Podikiri was done initially. Avanakela Mutila Naligaram Kiri was done locally. Pirichil and Navarakiri was done. Then Dvipanchamula Divasti was also given. The third visit happened last year. It was again after a period of 9 months. She said that she had occasional pain in the hip joints. She had no pains while walking. We continued with, but she was a bit averse to kashayams and all this time, so we had given her Dhanvantaram Kwatham. And Mustadi Marmam Kashayam was given this time. Gugulitikta Gridam were continued. Then Pirichil was done. Local Navarakiri was given only on that area. Rajyabanavasti was given and Upanaham was done. So the investigations revealed abnormal morphology of the head with sclerotic changes in them. So the symptoms were almost gone. So this was a case in which we were very skeptic because it was stage 3 and all, but usually when stage 3 or stage 4 comes, we usually tell them that it would be difficult. But in this particular case, she had got good results. Maybe her age was also a factor. The Ayurveda Shala therapies that were found useful during the treatment, there are a lot of treatments that go on, but what we would like to mention is this Avanaka, Ummatil. Avanaka is Erandam, Ummat is Dhatura, and Naligaram actually, it is coconut, grated coconut. Then Dashamula Sudhakshiradhara, which is used in Vata Shonidam. Dr. Jikku was also referring to Vata Shonidam during the treatment. So Dashamula Sudhakshiradhara, it is said Sadhya Shula Nivarnam. So if a patient is coming with pains and all, we could usually use it, and we find good results with that. And Navarakiri and Ragikiri, whole body Navarakiri could be done, but usually in our place, whenever the patient is a bit fat and all, we are using Ragikiri. The other treatments are also there, but I thought I would just mention the most important thing because of the constraints of time. The medicines that are found useful, we all know about Gugulitiktakam, we all know about Dhanvantaram Kashayam, we all know about other medicines which we are being given, but few of the medicines that are not usually common is Ketakiyada Tailam and then Rasatailam. Rasatailam, as you know, it will be replenishing the Majjadhatu also. Mahasneham. Mahasneham internally also can be given. There were cases in which internal things. Then Mahabala Tailam. Mahabala Tailam is found to be effective. We started using it especially because there are certain people like Jain community and all who are vegetarians. They won't take anything related to these things with non-veg and all. So Mahabala Tailam we were using. And it is slightly more potent than Gandha Tailam, I felt, with my personal experience with Gandha Tailam and Mahabala Tailam. Because Gandha Tailam we also know, but Mahabala Tailam can be used in such cases as well. The Vasti we all know, Tiktagradam, Dhanvantaram Medibagam, milk one, Tiktarashradagradams and all. Rajyapana Vasti could be a good choice, especially in the last case when I said that Shukla Dhatu and all those things were to be considered. Rajyapana Vasti is more Brahmana in nature. Dvipanchamuladi Vasti, again, it is pretty pain relieving as well. Kshiravasti we all have already discussed in the earlier presentation as well. Then this is the medicine which we have been giving thanks to late Dr. P.K. Warrier sir. The Balachurnam we were giving in most of the osteoarthritis cases, a lot of cases we give, and it always gives us good results. Balachurnam was usually given with milk. Sometimes certain people say that we won't be taking with milk, we mix it with ghee or something, and sometimes we give it with juice even. So Balachurnam was being given. The second addition to that, it's Asti Samharati Churnam. This is Bhagnadikaram Chakradatam. So for the bones, it is said to be more stronger. It has given good results. The second thing is, since Asti Samharati Churnam is not available in the market often, Laksha Gogulu was given in the follow-ups where the patients can procure it. It also contains Asti Samhara and then Ashwagandha and all. There is also Gogulu in it. So it is found to be effective. So finally, when it comes to Astikata Vata, we know that the Prayoga of Tiktarasa Siddha Hrida and Kshira is then. Kshira is considered best in nourishing Asti Dhatu and controls Vata. That is what it is. It is a routine thing. So this is what we have about the clinical experiences which I wanted to talk to you about. But then our clinical experiences is incomplete without mentioning what the patients usually come to us with. The patients who are diagnosed with avascular necrosis, as a matter of fact, any other diseases, they'll first go and consult Google. So in the Google will show that treatment can slow the progress of avascular necrosis, but there is no cure. Most people who have avascular necrosis eventually have surgery, including joint replacement. People who have avascular necrosis can also develop severe arthritis. I agree with most of the things. But avascular necrosis need not go to the later stages. That is what I know from experience. It is not that every avascular necrosis will lead to a condition where you would require joint replacement, provided we interfere in time. That is very important, because prognosis is something different. The patients who come with us with this prognosis talk to us after 1 year of taking treatment. They usually are coming back, not opting for the eventual surgery that is mentioned. So that is something that gives hope for Ayurveda, that we have possibilities in Ayurveda which can be done. Now let us see how it happens. In the avascular necrosis part, there is something called Perthes disease, which was mentioned in the first things. There was 4 stages that were mentioned. So we know that the patients who are young are usually move faster and have better outcomes. But after a particular age, they may not pass through the same stages because the bones have formed and that it might not be so easy. So in 4 stages, initial was the avascular necrosis stage. It is for the kids when they have avascular necrosis, we call it Perthes disease. And then there is a fragmentation and resorptive stage in which the breakage happens. In this resorptive stage only we can give vitamin D and supplements and all. So whenever there is there are receptors in the parathyroids which may be speeding it up. So that is where we could add some medications into it. Then the 3rd stage would be the reossification stage, where bone formation happens, and the final one is the heal stage. So these 4 stages happen in children. And when I was speaking to it, since because of our HMS systems and all, we were not having a lot of X-rays of the Perthes disease earlier, and in the short period I couldn't collect. So Dr. P.M. Warrior sir had a patient whose X-ray he had. So he had given me this Perthes disease one. You could see in both the cases, this is a period of 1 year. So usually when the stages, in the 3rd stage and all, it takes more longer period. But after our medications, you feel that the regeneration has happened also. The reossification stage and all, and the patient was actually symptomless. From what he told me, he was jumping from places, and his orthopedician told him that he is fine. So it was a child. He was 7-year-old, I think. I was from Kerala only. So this is an X-ray. So what I would like to tell here is we are able to reverse it in children, and we believe that we are not able to reverse it in older people. That is what the modern science tells us. But with Ayurvedic treatments, it is also possible that people are being able to arrest this disease. There was a patient who came for 3 times in Ayurveda in the hospital. And then this time, because of the cost and all, he said, and I had referred the same patient to the charitable. So he's in the army. He's still going with his usual duties. Of course, he doesn't go for the marching and all, but he's still working. And he's managing quite well. So regeneration is possible. Regeneration is possible because if what we can do in childhood, we are able to do it in older age, which is what our late chief had showed us with his example. Because in early 90s, when a person is trying to regenerate something that is supposed to be something that we say that it is common. In older ages, we feel that the bone formation and such things may not be so fast. But he took it, and within 3-4 months he could show us a result. That was his conviction in our Shastras. What we are losing is that same conviction. So this was the, since the child cases were there, this is a particular MRI of two people. We can always say that in the first impression it is bilateral avascular necrosis of grade 4 on the right side and grade 3 on the left side. In the second one, after an year, not a year, 1 year, it is 2 years, it shows it is grade 2. This is the same patient's things. Either the radiologist made a mistake. If the radiologist made a mistake, I have nothing to say. But if it is not, then it means that somehow something else also has happened. He was taking a treatment, and last year I saw the same patient. He was here. He did not have any pains. However, he did not allow us to write the same thing in the case sheets because he said that his insurance will not pay. So he was Dr. P.M. Warrior's patient, and he had suggested Navara tape for him. Nothing else. Navara tape only to do it and take the medicines, whatever was there. And he had done his PhD and all. He was quite happy. So this is the kind of results we are getting. And when such results we are getting it, functionally we are seeing the patients improved. We are seeing that improvement is there and there is no symptoms left. So I don't know why we have to believe that it cannot be reversed. Maybe to some extent it is being done so. So I'm going back to Samir Ali sir's mentioning of that this stem cell therapy. Maybe stem cells from outside will not be so effective, but if we can stimulate the stem cells that are inside us with the medications, with Ayurvedic medications which may be working, I think we could combine the Ayurveda Chikitsa concepts and this recent advances in this stem cell therapy. We could do more research and all. So the integrated approach could give or revolutionize the regenerative medicine which is now coming into the forefront. With that, I almost come to the end of my presentations. I saw a lot of quotes that were being done in the final lines. So I would like to quote our additional chief physician, Dr. K. Muralidharan, who in one of his rounds had mentioned that Ayurveda Chikitsa improves the quality of hope in the patients. Actually, the patients who come in a very hopeless conditions, after the treatment, they go with an improved sense of hope, which is all I need to speak. And I think some of you may work on some parts. I may have fumbled here and there. I may have not been able to convey what I wanted to in the full sense, but I think somewhere if something makes sense, kindly work on it. Thank you. You have been a wonderful audience. Thank you.
Thank you so much, Dr. Nishan Narayan. Our managing trustee will be presenting a memento to Dr. Nishan Narayan now. Sir, please. Thank you, sir. Now the presentations are over. It's time for discussion. During the discussion, the panel of physicians would address the queries also. We invite Dr. T. Srikumar, retired professor, Vaidyaratnam Ayurveda College, Ollur, to moderate the session. Dr. Srikumar sir, former professor, HOD and vice principal of Vaidyaratnam Ayurveda College, Ollur, also served as the principal of PNNM Ayurveda College, Shornur. Presently serves as a senior consultant there. He is a renowned academician and clinician with a countable span of experience of around 37 years. He has authored commentaries to classical text, Ashtanga Hridaya Sutrasthana and Charaka Samhita Sutrasthana. A textbook of Ayurvedic physiology, Maulika Siddhanta, Chalakatantri Janya Rogangal are the other texts written by him. Sir has presented scientific papers on various national and international platforms. Sir is also a member of the editorial board of Aryavaidyan, a peer-reviewed journal being published by Ayurvedishala Kottakkal. Sir, please.
ബാക്ക്ഗ്രൗണ്ടിൽ ഇരുന്നോട്ടെ, ഞാൻ പിന്നീട് മാറ്റേണ്ടി വരും. അല്ല എന്താണെന്നറിയോ, എനിക്കിതിൽ ചിലതാണ് പ്രസൻറ്റ് ചെയ്യേണ്ടത്. ഇത് കണ്ടാൽ മതി. അല്ല അത് മാത്രമല്ല, ആ സമയത്ത് സ്ക്രീനിലേക്ക് പ്രസൻറ്റ് ചെയ്യും. ഇപ്പോൾ ഇന്നിപ്പോൾ ആദ്യം ഇതല്ല പറയാം, ആദ്യം എൻ്റെ പ്രസൻറ്റേഷൻ അല്ല, ആദ്യം ഇവരോടുള്ള ചോദ്യങ്ങളും അതിൻ്റെ ഉത്തരങ്ങളും കഴിഞ്ഞിട്ടാണ് ഞാൻ പ്രസൻറ്റ് ചെയ്യുന്നത്. ഞാൻ എന്തെങ്കിലും സിഗ്നൽ കാണിക്കുമ്പോൾ Respected PM Ariyar Sir, the Managing Trustee and Chief Physician of Kottakkal Ayurveda Shala, my dear friends, ladies and gentlemen, now is the time for summing up. As moderator, I would like to, I have 3-4 duties conferred upon me. So, the first instance, I'll go to the presentation of Dr. Samir Ali. I was keenly interested in throughout his presentation. I wonder why he is working as just the head of the department of an institution, because he ought to be a better teacher, a best teacher, I think. His presentation was like I was witnessing his presentation and hearing each and other sentences of his presentation with utmost interest, like students. So, congratulations, Dr. Samir. His presentation was basically his stage by stage ischemia, progressing into necrosis, and then to severe arthritis, then the arterial blood supply, the various arteries, including the medial circumflex artery, which go into the making of the total blood supply, then various figures like digital subtraction figures, the etiology and causes of AVN, fractures, cutting of the blood supply, the garden 3 fracture importance, then a dynamic screw fixation versus cancellous screw fixation, delayed fixation, and all these things. Conservative management, non-traumatic, the cascade of what is happening in the body in non-traumatic type of AVN, steroids, increase of fat cells, osseous compression, then vascularity, ischemia, everything. Everything was so beautifully pictured in his presentation, and also the importance of alcohol in the as a causative factor of AVN. Then the symptoms of AVN, differential diagnosis, surgical options, early surgical options, stage 2, stage 3, the formation of fibrin. See, each point was addressed within a very small period, time frame, but at the same time very eloquently. So I wonder why. Not only that, I wonder why I was not, as a teacher, I was not having this much quality as a teacher in teaching, because I was a teacher for about 35 years. When, I congratulate his presentation. Then number 2, Dr. Jiku's presentation. He is from our fraternity itself, Ayurvedic management of AVN. Right from the point of application of medicines externally, he was talking about various aspects like Jalavaka, then the etiology classification through his own spectacles, the etiology classification of AVN, presentation, clinical examination, the various figures he has delivered on clinical examination and videos also, differential diagnosis of various conditions, management upon stages, samprapti concepts, corrective measures, rehabilitation, strengths, our strengths and our weaknesses, then phases of management, based on age. All those things he has beautifully elaborated upon you. And I am happy to witness his presentation. The third one about Dr. Nishant Narayan of Kottakkal Ayurveda Shala. The one crucial question he has put at the beginning of the outset itself is whether it is irreversible or reversible. See, at the end of his presentation, he has come back again to the first question that many of the cases are reversible. And one can have a concept that it is irreversible, but there are some cases at least, there are a few cases at least which can be made reversible. That was his presentation, and unbelievably with small medicines like Belachorna, like that, one can make up the gap that we are witnessing in day-to-day practice in the management of AVN. And subtle nuances of action of medicines at various dhatu levels. Although he may have purposefully avoided the word rasayana, all the while from the beginning to end he was speaking about rasayana itself, means including the stem cell therapies and all. So that is about the presentation side. Let us discuss some questions, certain questions that have come from the audience. The first question naturally goes to Dr. Samir Ali. The question I'll read as such: after which grade of AVN surgery is a must? The question can be translated thus, that which grade of surgery is commonly amenable for surgery?
Okay, nowadays the practice is, if it's the stage 4, significantly affecting the patient's activities of daily living, we will recommend total hip replacement. In stage 2, 3, we'll try the stem cells therapy. That is what we recommend. The one thing why the stem cells have a potentiate or capacity to regenerate to any sort of cells, because it's like an umbilical cord cell or like a sperm. It is a stem cell which can differentiate to any sort of cells in our human body. So we take a marrow and just purely inject, doesn't mean that it will grow into an osteoblast. How the stem cells know that I have to go into an osteoblast? That is why the stem cells is taken from the marrow, which have been cultivated externally, and cultivated externally we need osteoblast, because avascular necrosis is a disease which uniquely affects the osteoblast. It's not affect hepatocyte, it not affect hepatoblast, or it's not affecting any other cells. It is affecting the osteoblast. So the stem cells need to be cultivated to form a osteoblast. And if you inject that osteoblast in a high concentration, there is a high possibility that this osteoblast will regenerate to osteocyte. So that is a basic dictum. So a patient have a severe, because that is a little bit costly, that is a problem. This stem cell kit itself costs around nearly 1.9 lakhs. So the many patients can afford it. Even some insurance companies support it, but otherwise only a subset of patients have insurance. So those patients doesn't have an insurance, we recommend go for a cord decompression and support with a non-vascularized fibula. That's a relatively less morbid procedure, and those procedures is not going to hinder the process of the disease, because if the patient is at 25 years, we do a cord decompression, doesn't mean that the disease will stay at that point. So that is why I recommend at this point of time, if you do a cord decompression structured with a support with a fibula graft, if other treatments like Ayurvedic treatments help for the patient to stagnate the disease process at that point, will be the huge benefit for the patients. Because allopathy medications can't support with the medications to prevent the progression of the disease. So if you do a surgery, do a cord decompression, remove the vascular bone, support it, then the Ayurvedic medicines can help to regenerate the rest of the medicine and stagnate the process of the disease, will be the great help. that is why the integration have to happen together.
Thank you, Doctor. You have narrated in detail. But unfortunately or fortunately, the second question also is a reflection of the first question. Do you have clinical experience in stem cell therapy with respect to AVN management?
Yeah, this, the stem cell therapy, this one just recently launched around 2 years only. I started only 2 cases, that is only in around 6 months back, and another one is around 2 months back. I told you the cost is a main factor. Unless the insurance supports, many of the patient can't afford it. And also, the thing is that we don't have a data to say that the patient is spending so much amount of money. The patient will ask the question, will it stop the disease and I will be back to 100% a normal? We can't say because we don't have a result. We have only short-term results. But the short-term result, the first patient, the 6 weeks MRI patient, 6 months first patient, we took an MRI almost 3 weeks back. That is very promising. The geographic lighting areas has gone. There is some amount of signal changes, but it is being preserving. So that is a good sign. But we don't have anything to offer. So clinically as well as theoretically it is going to help, but it is helping. That's it.
The third question is directed to both Dr. Shamir Ali as well as to Dr. Jikku. How can we decide on how to proceed further if conservative Ayurvedic management is preferred? Any suggestion with respect to stage if we reverse the stage of AVN? How can we decide on how to proceed further if conservative Ayurvedic management is preferred?
Regarding to decide whether we need to continue with conservative Ayurvedic management, we can definitely depend on the clinical examination of this particular patient along with radiological finding. Second thing, the demand of the patient, that is much important. If the patient need to continue sahasa, repeated strain injuries, weight bearing activities, then definitely our prognosis may not be much good. But if the patient is able to take rest in the initial phase, and in the later phase only the patient need to maintain activities but bit less than earlier, then definitely we can help that patient. So it should be definitely customized based on that patient's demands, and the clinical examination and radiological finding should match each other. And whether we can have a try also in this situation for a period of 8 weeks. After 8 weeks, if the patient is not responding with conservative management, then we can refer that particular patient. That is what I am following in my practice.
I will just tell a case scenario. Around 2016, there is a veterinary doctor. She had taken short course of steroid. She stopped. She developed an avascular necrosis. She presented me at the stage of 2A or 2B, doesn't remember. I did a cord decompression. I did a non-vascular fibula graft. Around 1 year later, patient's symptoms recurred. Initially, she had night pain relief and everything. 1 year later, patient's symptoms recurred. Then I suggested, she's around 32 or 33 years. I suggested, that's in 2016. Post-surgery, it became 2017. I advised her, if your symptoms is affecting, you go for a total hip replacement. So she asked me, sir, I can try Ayurvedic treatment. I told her, okay, definitely you try, because the total hip replacement is an elective procedure. Any day, any time in your convenience we can do. So anytime we can do a total hip replacement. So you try other modalities of treatment, and now it's almost 2024. The patient is, I seen her in the last week in another OPD, in the gastro OPD. I asked, how are you? She told me that I am okay. So then I took, for curiosity purpose, I took her, I took an X-ray. The collapse increased, but the patient is not symptomatic. So most importantly, the thing which decides the treatment is the patient reported outcome. How the patient feels his disability is the one which drives the treatment. You can say, oh, X-ray is very bad, you have to go for a total hip replacement. The patient is symptomatic, then only forget about the X-rays. But X-ray you can keep it for your research purpose. That's what I suggest with Jikku and all. And previous years also, a lot of case 2, 3 stages of AVN you are dealing. So once you complete the treatment at 6 months, X-ray won't show much evidence in 6 months. So you get the patient at 6 months, repeat an MRI, document it, and after 2 years, take an X-ray. If there is a significant improvement, that means you can prove it and note down the patient reported outcome measures. How is the Harry hip score, who score, everything. If the patient have a symptomatic relief, plus MRI or radiologically also there is a benefit, you can 100% assure that this treatment is going to benefit.
Is COVID vaccination having a role in the flare-up of avian?
The COVID is a very unfortunate situation for the, I will say, last 2 years. I done almost 23 to 25 total hip replacement, including 5 doctors. So all those patients have developed severe COVID. They got hospitalized, especially in the ICUs. Once they're in the ICU, the COVID flare-up, the only treatment to save the life is steroids. So they've taken high dose of steroids. So we don't know whether the COVID is a culprit or the post-COVID steroid is a culprit or the vaccine. I don't know, because one of my OT staff 2 weeks back presented with a numbness of the hand. So when I examined, she doesn't have a radial or ulnar pulse. Then I consulted with a vascular surgeon, noticed that she have a 4 centimeter long thrombus in her axillary artery, the second part of the axillary artery. So no cause for reason, the only thing that she had a COVID. So COVID is and during the acute COVID, I have seen a young boy, 18, 19-year-old boy, came with both lower limb amputated because of the massive thrombus in the femoral artery. Both lower limb gangrenous and amputated. That was so sad situation. So we don't know whether the COVID is a culprit, post-COVID treatment, steroid is a culprit, or vaccine. Now there's a lot of background stories is coming with AstraZeneca's vaccines. So definitely vaccine is the one which produces a small state of disease. So those who are genetically predisposed can have a thrombus effect. Because that's why the COVID vaccine takes, you will feel some chills or rigors for 2-3 days. That means it's producing a small dose of COVID in your body. So don't know whether it will produce.
So many guns are pointed at you, Dr. Jikku. Let me have my first shot. Is there any particular Ayurvedic treatment which is found to be most effective in the conservative management of avian? Is there any particular Ayurvedic treatment?
We should follow the protocol. We can't tell that we are following the protocol, so we can't tell this is much better than this. We cannot explain like that. Definitely we need that particular protocol to be followed, and that protocol is giving the result. So each and everything, like when we explain Tantra Yukti, Dravya is Pradhana, Guna is Pradhana, Karma is Pradhana, everything is Pradhana, but we should follow the protocol entirely. That protocol is giving the result. If one is not following, then definitely we won't get the complete benefit. So there is no special particular treatment as far as my knowledge.
Now the second one, can you explain the Anagneya Sweda methods that can be tried in avian?
I need to provide the importance of rehabilitation. So I mentioned rehabilitation will definitely give the effect of an Anagneya Sweda. So I explained regarding the explanation of rehabilitation. I think it is better to opt internal sneha, internal shodhana therapy better than external therapies in avascular necrosis progressed situations as it is a Vadarakta disease. If it's a Uttana condition in the very beginning, as I already explained in the Sanjaya Avastha, in that situation definitely Lepa Parisheka Avagaha will provide result. Avagaha is definitely a very good option if the patient is able to sit for 5 minutes. Definitely Avagaha Sweda is very effective, but it won't give much result in the later phase Gambhira Avastha. So in Uttana Avastha, we can opt Sweda. Rehabilitation can definitely give this result. Regarding that question, I think this is the answer.
Then one curious question is there. You have mentioned Sadhya Virejana as effective in avian. Any reference available?
Actually, Sadhya Vamana and Sadhya Virejana is for Koshta Shuddhi, which can be done in each and every case, any situation. It was followed by Ravi Shankar Parvaja sir. Now also sir is doing the same. So when I was with him, I studied this. Actually, it is effective. In all cases, in avian also, it is effective as part of Koshta Shuddhi in the very beginning. I think, I don't know the exact reference to be quoted here.
Again, kindly share the experiences regarding internal use of Rasathilam in the management of avian. I think yourself and Dr. Nishant Narayan has already given much references. Anyway, the question is there. Can you throw some more light upon the matter?
Definitely, Rasathaila is effective in this situation. Regarding if the patient's age group is below 16, then in X-ray and MRI, there is documented studies. When I was doing my PG, present Trivandrum HOD Subi madam was dealing with one case. Yesterday on discussion also, madam documented the MRI of children below the age of 16, before the treatment, after the treatment, present situation. And in NRIP, Pradap sir shared one case. This patient is from Hyderabad. Just like Nishant sir today showed the MRI from grade 3. On later MRI after 2 years, it is presently as grade 2. And the patient's quality of life also, Harris hip score is also very much improved. So in such situations, definitely Rasathaila can be incorporated at the phase of Rasayana. At the phase of Rasayana, definitely we can opt Rasathaila. It is useful.
Dr. Nishant Narayan, the next question. Commonly, avian affected bones and the Ayurvedic management.
I think I already explained it in the first thing. There's the humeral head, hip. Hip is what we get mostly. So the Ayurvedic management is what we had explained all the cases. So the thing is, the stiffness and whatever it comes, we initially go with a Rukshana Kriya. It may be Dhanyamla Dharam. It would be according to the patients. After giving a Rukshanam, then we can add on something like a Rasayana sort of medicines, or the medicines which can be given for a longer period. It will be slightly Brahmana in nature, which will be giving some kind of nourishment to the particular bone. In the final, usually the patients who come here are 14 days or 21 days. When they are going, we will be giving some Rasayana sort like Balachurnam. So sometimes Guglitiktam is given for a longer interval. In Guglitiktam, when we are giving at the night time, we may add a Pravalavasmam also. This is how we treat it. So initially it is always Amapachanam. Then slowly improve the circulation. There is something we do like Avanakala Ummatela Naligaram Kiri. So when we are doing it, we think that we are going to give some kind of vasodilation there. That is the reason why Ummatela is used. The oils which are used, that also we alter according to the patients. Sometimes Durduradi Thailam and Rasathilam, or Durduradi Thailam and Murivanna will be mixed together for application on the particular area and locally given. These are the kind of things that we do while we are handling the patient. In OPD also, the same thing can be done. I think Dr. Jikku has also explained that, Pajanamradam Kashayam and all. Initially we give a Kashayam which is Pajana in nature. Then later on we can give it something that will give effects in the long term. Guglitikta Kritam gives. As a Rasayana also it can be given. Kurundotipadi, that is the reason why I said something so simple as Kurundotipadi can be used. Pravalavasma actually is also coming into the fore because there are studies of corals being used for, I didn't get the link that, but these are things that will define the future management of not only avascular necrosis, most of the osteo conditions. Thank you.
One more question to you, clear question. Role of Rajayavanavasti in avian management.
Rajayavanavasti, if you know, the ingredient contains Mamsarasam also, which is important here. It has been already been mentioned that for the replenishment of Majja, the Majja causes the Saushiryam, Majjak, when it goes down, it just causes the sausharium of bone. So for that also, Mamsara, so Vasti, when you are giving, why actually we give Vasti is not just for cleansing. When you are taking a medicine from the oral route, by the time it reaches the absorption levels, what happens is it mixes up with a lot of things. So Vasti is the nearest and the most important treatment for the Vatika kind of conditions. Rajayabana Vasti, which is a Brahmana Vasti, could be given in the later stages, maybe after giving initial 1 or 2 Vastis, like start with the Madhutailikam, go for Kshiram, then go to Dvipanchamuladi or Rajayabanam. That way it gives good results in the degenerative conditions. Thank you.
Thank you, Dr. Nishan Narayan. See, here there is a problem. The entire further questions are dictated by one author. It is one person who has asked all these questions. And I am quite unable to differentiate these questions. I think it is better to differentiate the disease than the questions. To Dr. Samir Ali, differential diagnosis in OPD between sciatica, bone cancer, osteoporosis.
Sciatica, osteoporosis and malignancy, cancer. Okay. Sciatica is, we'll start with one by one. Sciatica start with back. Patient will have a gluteal trigger point, and when the patient start walking, the patient will start feeling the pain radiating to the calf muscles and can up to ankle joint. Patient take rest, especially when she lying down, the pain reduces. That's a classical radiculopathy. And the same pain aggravates when the patient sitting down or bending forwards. So that is the sciatica. So along with the sciatica, you should ask one more question, whether there is a degenerative problem or there is an instability pain. If the patient have a significant back pain, especially in the early morning, and patient get up, the back pain reduces, then this is more of a degenerative back pain. And ask the patient whether the patient have a pain while turning towards sides, getting up from a sitting or laying down. That means basically the position of the back changes. If she have a pain, that shows there is some instability in the back. Can be listhesis or can be a degenerative lysis or whatever it is. So that is about the sciatica. Then second is an osteoporosis. Definitely comes the age of the patient. Especially after 55 to 60 years, especially the female, they have a generalized body pain. That's how we differentiate, especially the females. And after some activities, especially they have a pain in the shin of the tibia, especially the bone pain rather than the side pain. Axial skeletal pain is the one which the patient will have in osteoporosis. Then comes the malignancy. I don't know if it's a bone malignancy or any other malignancy. Suppose it's a bone malignancy, then you have to see the age of the patient. Patient is less than 15 years of age. Think about the malignancy will be osteosarcoma or Ewing sarcoma, giant cell tube. Those patients will have other constitutional symptoms like fever, weight loss, loss of appetite, night pain, classical night pain. Patient will have a pain during night. These are that's known as the red flag signs. These are suggestive of a malignancy. And when the patients come to the age, then there's a free period of 20 to 50 years. Usually there is not much severe bone malignancy. Then after the 50 years, you think about two types of bone malignancy. One is a primary malignancy, that is a multiple myeloma. Again, the patient have a weight loss, especially the scalp tenderness, skull tenderness, bony tenderness, vertebral pain, night pain. Then the secondary malignancies, the cancer from any other part of the body spread to the bone. This cancer pain is a continuous pain. It's not relieved with rest, not relieved with activities. It's a continuous pain, even not responding to painkillers. That is our system. Then complemented with the blood investigations, MRI, bone scan, all those things help to differentiate between different type of cancers.
The next question goes to Dr. Jikko. You have advised to give soup as a management strategy. Is the soup of beef or of lamb more effective?
Definitely lamb is more effective, no doubt.
Then one question to Dr. Nishant. I cannot decipher the questions.
Actually, somebody has written about Podikiri drug. Podikiri drugs. Okay, and but then Manjal Kidi. Okay, Manjal Kidi actually. Manjal Kidi actually is it's very common. You have haldi, turmeric, then you have malare, chenjilium. And what makes it more important is it has egg white also in it. So it is a nourishing kind of thing, but when we use it in with ginger juice or something, it has anti-inflammatory action as well. We give manjal kiri, and after that manjal kiri, the paste which is left, you can usually put it as an upanaham also. In degenerative conditions, it is usually useful. Then Changalam Paranda Churnam. Changalam Paranda Churnam, I think everybody knows. I don't get the question here. Then Kshirabala 101, the use. Yes, Kshirabala 101 can be used. It contains Kurundoti and all. Kshirabala can be given as a rasayanam also. Maybe 2 capsules. I didn't get what the person was trying to convey, but Kshirabala 101 can be used as a main body for kashayams like Mustadi Marmam or Dhanvantaram Kashayam.
The further questions to Dr. Samir, etc., and Dr. Jikku are delivered to them. When they have time, they will answer the questions. Let me move on to my further proceedings. സ്റ്റേജ് മേലേക്ക് വയ്ക്കുകയും വേണേ. അല്ല ഇത് see, I do have some 2 or 3 points to add. It may not be addition in all, because all the stalwarts in the field have presented their own views. But then I have 2 or 3 important messages to give you. That's why I am here, despite the fact that I am a moderator. I am here to present 2 or 3 points. The concepts of Ayurveda and concepts of Ayurveda practice in Ayurveda in avian femur. See, such a disease is not mentioned in Samhita texts. We all know that avian femur has not been mentioned as an entity. Is it a new condition? Was the condition not there during the period of the Samhita Granthas? It's not like that. Such conditions should have been there, even in those times. But is there any classical nomenclature necessary for we to give a classical nomenclature like Vadaroga of Asti, something like that? I don't think that also is necessary. I better think that the translation or bridging of the terminologies and the diseases is to be done by the concepts. What concepts we have got about a particular condition. depending upon the samprapti. And thereafter, stage-wise management is to be done. What I am trying to tell you, even if the time is over, about 12:55, is that systemic samprapti is to be zeroed in to regional scenario while doing therapies for such conditions. Because everybody are ardently talking about Asthidhatu Kshaya. But we all know that Asthidhatu Kshaya is only local in this particular condition. It is not a generalized Asthidhatu Kshaya. So if we give medicines and if we give therapies to stimulate the Asthidhatu production, generally, systematically, what would happen? We want only a local normalization of Asthidhatu and regeneration of Asthidhatu. But the treatments we are giving will be systemic. There is a disparity there, I think. So how it can be overcome? Ayurvedic concepts of avian can be blood supply to the bone is jeopardized. Local Asthidhatu Kshaya occurs. Rekta Vahasrodas, Asthidhatu, Asthivahasrodas, all are involved. The key pathological features are injury or toxins. Injury, we Shalya people translate injury as Varna, whether it is an Abhyantara Varna or a Bahya Varna. Then toxins. Toxins means it may be the Visha, products of inflammation or organisms. Then Ama or Srodorotha or Srododushti, Adipravarti Sangova Siranangranthe Obiva Vimargatova Gaminam Srodasandushti Lakshanam. It can also be translated as Avarana or arrest of Dhatu Parinama, local arrest. Local, I will always tell. Because Dhatu Parinama is elsewhere normal, elsewhere in the body it is normal. Only locally it is aberrated. Local arrest of Dhatu Parinama. Then you can also have Roga Marga taken into consideration, the affected ojas, Marma Bhanga, Shatkriya Kala, etc. The management should be stage-wise and individually prioritized. There are arbitrarily, you can classify the avian into two types. Number one is Nija variety, and number two is Agandu variety. The first one, non-traumatic, caused by other diseases or is idiopathic. See, why don't you consider it as local Dhatu Kshaya or local Rajekshma. Can you observe it like that? If you can observe it like that, I think the treatment also, you can give good treatment also. The principal doshas to be tackled in this Nija variety are Vada and Kapha, which causes Rodorotha to Rektavahana, and the division of Vada here is Apana. Whereas in the case of Apana Vayu, the cause is a trauma. Whether it can be direct or indirect trauma, or maybe it may be surgical trauma also. The doshas involved are Vada and Rekta. To be considered at par with Marma Bhigada of Lohidaksha Marma. Concept of Sandhi Bhagna also is to be considered. Lohidaksha Marma, you may be familiar, Urimule Lohidaksham, Handi Patcham Asrikshayat. Handi Patcham Asrikshayat. Again, Sushruta has reiterated that Urimule Lohidaksham Nama Tatara Lohidakshayena Patchakadaha. But I would like to tell that this Patchakada or Pacha is to be translated thus. Here Patchakada should be interpreted as the inability to use one part of the body only and not one side of the body. Here my Honorable Guru Professor C.R. Agnivesh in his textbook of Ayurvedic anatomy has written, common are the medical conditions like avascular necrosis of artery, supplying the head of the femur through its surgical neck, eventually causing morbidity of the thigh of that part. I follow this discipline. Lohidaksha Marma, you can see with the main vessel, femoral vessel, etc. But the affected is microcirculation only. Means again I am coming to the point, local. It is the femoral vessel is normal. Only the branch of the femoral vessel is aberrated. So the affected is microcirculation. The local microcirculation of recta aided by vada is blocked. You can consider it as srodorotha. Blood becomes stagnated, microthrombi are formed, which is caused by kapha and medas. At par with, you can, one more thing I would like to tell you, after which I will finish off my presentation. This condition is to be envisaged in the light of ischemic heart disease on one hand. Ischemic heart disease, yes, ischemic heart disease, coronary artery disease itself. But it's a systemic condition, yes, this is a local condition. Or almost every virtue of ischemic heart disease is there here. Only thing is the circulation aberrated is microcirculation and the part affected is hip. Otherwise all are the same. And also cerebrovascular accident causing Patchakada. Here also only a part is affected. So whatever treatment you are giving for ischemic heart disease or whatever treatment you think of giving to ischemic heart disease or cerebrovascular accident, that can be instituted here also, or deep vein thrombosis also, like that. This block hinders the local dhatu parinama according to Khaleka Bodhanyaya or Kedarivulya and avian occurs, which is to be considered as a spectrum of local dhatu chaya. The samprapti, the roads of samprapti of Nija and Agundu, though coming from two different parts, meet together at a single point just before Vyakti Bhava of the disease. And hence, the initial management of both these types differ, but the final pathway of management remains the same. I'm not taking much of your valuable time. Just one thing I'll tell, that the management of endogenous means a Nija type of avian, and of exogenous type of avian differs. The endogenous is further divided into Bahiparimarjana and Andhaparimarjana. It is again divided into stages. Stage 1, Upanaha. Somebody was asking that question. Upanaha for alleviating Srodorotha. Stage 2, Tailathara for Vadaharitva. And stage 3, Brahmana therapy. Andhaparimarjana, stage 1, Amahara therapy. Stage 2, Vedanastapana therapy. And stage 3, Dhatu Poshana therapy. Likewise in exogenous also, that is due to injury also. Bahiparimarjana is divided into 3 and Andhaparimarjana is divided into three stages. Number 1, Sandhana. Number 2, Stiratva. And number 3, Brahmana. Likewise, Andhaparimarjana, stage wise, the first stage Jivana, second stage Abhyandara Vranahara. Abhyandara Vranahara means like, for example, using Guguludiktakam or Varanadi, etc. And stage 3, Dhatu Poshana. The practical therapeutics in not so early diagnosed cases of avian goes like this, because I have treated some cases and most of the cases I have got significant relief also. But I have given Snehabana initially with Gugluta Gradam plus Gandhadairam. Gugluta Gradam plus Thailam means 10% of Gandhadairam only. Suppose you take 100 ml of Grada, 90 ml of Grada will be there and 10 ml of Gandhadaila will be there. And the diet predominantly of foxtail millet. Foxtail millet means Priyango. Priyango is mentioned in Ashtanga Hridaya. Bhagna Santana Krat, Tatra Priyangur Brahmani Guru. Then, depending upon the stage, you can give Mustadi Marma Kashayam or Guglutan Kashayam. Then, Shadharanam. Shadharanam of Suchruta, I am telling, not of Vagbada. Means Chitragendreva Patha Kadagadi Vishabhaya. Chitragendreva Patha Kadagadi Vishabhaya. Vadavyati Prashamano Yoga Shadharana Smrada. Not one single entity in Shadharana is Vadahara. But ultimately together it is Vadahara. That is a prescription of Suchrada. Then Murvenna or Dhanvandaram or Shashtika Thailand can be applied according to the stages. So this much only I have to tell you. I am sorry to steal your valuable time. Thank you very much.
So the discussion is over. Thank you speakers and thank you Dr. T. Shukumar sir. We request you to please receive a memento from our managing trustee. Thank you, sirs. The technical session concludes here. Now it's time for the presentation of awards and prizes.
Let's begin the award ceremony. The first award, 56th All India Ayurveda Thesis Competition 2024 for Vaidyaratnam P.S. Vari Award. The first prize goes to Dr. Nimmi V.S., Assistant Professor, Department of Dravya Guna, Vaidyaratnam Ayurveda College, Thrissur. We request the audience to come to the stage and receive the prize from our Managing Trustee. The second prize is shared by 3 scholars, Professor Anandaram Sharma PV, Professor and HOD Department of Panchakarma, All India Institute of Ayurveda, Dr. Prashant Dharmarajan, Associate Professor, Department of Panchakarma, All India Institute of Ayurveda, Dr. Ashwati YS, PhD Scholar, Department of Panchakarma, All India Institute of Ayurveda. Dr. Ashwati will be representing all the 3 and receiving the prize.
Second award, Ayurvedian P. Madhav Warrior Memorial Gold Medal Presentation Competition 2024. This year the gold medal goes to Dr. Priya N.K., Final Year PG Scholar, Department of Panchakarma, VPSV Ayurveda College, Kottakkal. Second prize goes to Dr. Neisha C., Final Year PG Scholar, Department of Swastha Vrta, VPSV Ayurveda College, Kottakkal. Aryavaidyan S. Warrior Memorial Endowment Prize 2024 for the best outgoing student from VPSV Ayurveda College, Kottakkal for the year 2023. This year the award goes to Dr. Ardra M. Dr. Ardra M. from VPSV Ayurveda College, Kottakkal.
Aryavaidyan NVK Warrior and Aryavaidyan Madhavikutti Endowment Prize 2024. The first prize goes to Dr. Swati N., House Surgeon, VPSV Ayurveda College, Kottakkal. The second prize goes to Miss Aparna Gopal, Final Year BMS, PNNM Ayurveda Medical College and Hospital, Cherudurthi.
Jnana Jyoti Award 2024 instituted to honor Srimati Malati and late M.K. Devidas Warrior for the best outgoing female student from VPSV Ayurveda College, Kottakkal for the year 2023. This year the award goes to Dr. Ardra M. again from VPSV Ayurveda College, Kottakkal.
Now the winners of quiz program held in connection with this year annual Ayurveda seminar. The winners from EPSV Ayurveda College Kottakkal. The first prize is shared by two people. Dr. Deepika VM, second year MD Dravya Guna. Dr. Minu Majid, final year MD Manasroga. Second prize goes to Dr. Sophia Joseph, final year MD Samhita. Now the winners from Vishnu Ayurveda College Shornur. The first prize is shared by Dr. Akshaya Kartyayani MC, final year BMS. Dr. Shanina, house surgeon. Dr. Shanina, house surgeon. Second prize goes to Dr. Anarkha MS, final year BMS. Dr. Geetika MK, final year BMS. Dr. Gayatri TK, final year BMS.
Winners from PNNM Ayurveda Medical College Shornur. First prize Dr. Kavya C. Prakash, final year MD Shalyatandra. Second prize to Dr. Jia Jain. Ms. Jia Jain, final year BMS. Winners from KMCT Ayurveda Medical College Mukkam. First prize Dr. Simran P, final year BMS. Ms. Simran P, final year BMS. Second prize Ms. Anina Joy, final year BMS.
Now we invite Mr. Praveen Paul, the photo gallery designer, to receive a memento from our managing trustee as a token of our gratitude.
In connection with the centenary celebrations of Charitable Hospital, we have brought out mural paintings depicting the history of Ayurveda and Ayurvedishala. We would like to place on record the appreciation we have for the artist of the Institute of Mural Painting, Guruvayur Devaswam, who have done the mural paintings. Shri Govindadas KP, Abhinav AS, Aromal MG, Rohan KV, Sanesh CS and Karthik S. We invite all of them to the stage to receive a memento from our managing trustee.
Thank you, sir. Now we request Dr. K.M. Madhu, Chief Medical Officer, Charitable Hospital, to propose the vote of thanks.
Respected Managing Trustee and other dignitaries on the dais and off the dais. Now it's the concluding session and conclusion of our Ask at 61 now. We have two sessions. One is the inaugural session, which is very much encouraging for all of us in Ayurvedic fraternity, because Dr. Kattecha and Mr. Hanish has given us very good encouragement regarding this Ayurvedic system and our institution too. So I extend my gratitude to both of them. And in the next scientific session, we had very good, informative sessions from both modern side and the Ayurvedic side. See, the thing which was envisaged by our great founder Vaidyaratnam P.S. Warrior, that the both systems of medicine will should to be coexisted together, and it was the example in this hospital itself. And in all the seminars, Ayurveda Shala is giving this kind of informations. And first session was from Dr. Samir Ali. Dr. Samir Ali is a person from our side itself, and is a very great friend of our institution. And he made a very good informations regarding the modern techniques in the management of avascular necrosis. And he is a very great surgeon in Calicut. And I extend my gratitude on behalf of our institution and myself to Dr. Samir Ali. And second session was by Dr. Jiku alias Benny, who is a very promising doctor from Kerala. And he has made his contributions in the field of Shalyatandra as well as treating the avascular necrosis. And I think he made a very good information. He gave us a very good information regarding the Ayurvedic management of this avascular necrosis. So I extend my thanks to Dr. Jiku alias Benny on behalf of our institution and myself. And next was our own, colleague, Dr. Nishan Narayan, who is a very experienced person in our hospital, who made a very good presentation. And it was really an eye-opener, because he has made it, as the point was regarding that Vajigaranam, it is a very great eye-opener to all of us. And it's certainly, in Ayurveda Shala, most of our doctors usually have a very good experience, and they will present such things in the seminars yet to come. And I thank my friend, Dr. Nishan Narayan, on behalf of all of us here. Now, the moderation was done by Dr. T. Sri Kumar, who has a very good, record in the field of Shalyatandra, because he is a doyen in that field itself, because he has started a hospital of his own in Trichur, which is doing very well in this field. And I extend my thanks on behalf of our institution and myself to Dr. Sri Kumar, who is a very good friend of mine. ഇനി എനിക്ക് പറയാനുള്ളത് അടുത്ത് നമ്മുടെ പ്രിയപ്പെട്ട നാട്ടുകാരോടാണ്. കാരണം കോട്ടക്കൽ നമ്മുടെ ആയുർവേദശാലയുടെ എന്ത് പരിപാടി ഉണ്ടെങ്കിലും അതിനെ നല്ല രീതിയിൽ വിജയിപ്പിക്കുന്ന ഇവിടെ കോട്ടക്കൽ ഉള്ള നല്ലവരായ നാട്ടുകാരാണ്. അവർ കുറേയധികം പേര് ഇവിടെ വന്നിട്ടുണ്ട്. അവർ ഡോക്ടർമാരല്ലായിരിക്കാം, പക്ഷേ എങ്കിലും അവരുടെ സഹകരണമാണ് നമ്മുടെ ഓരോ പ്രവൃത്തിയും ഇവിടെ വൻ വിജയമാക്കുന്നത്. കോട്ടക്കലുള്ള ഓരോ നാട്ടുകാർക്കും പ്രത്യേകം നന്ദി ഞാൻ രേഖപ്പെടുത്തിക്കൊള്ളുന്നു. അതുപോലെ തന്നെ നമ്മുടെ ഇവിടെ ഇങ്ങനെ നല്ലൊരു പന്തൽ ഇവിടെ ഒരുക്കി തന്നു. അതുപോലെ നമ്മുടെ ഈ എല്ലാ സിസ്റ്റംസും, നമ്മുടെ സൗണ്ട് സിസ്റ്റമൊക്കെ ഒരുക്കി തന്നത് KMK രണ്ടത്താണിയാണ്. വളരെയധികം കാലമായി ആയുർവേദശാലയുമായിട്ട് വളരെയധികം ബന്ധമുള്ള ഒരു ഇൻസ്റ്റിറ്റ്യൂഷനാണ് KMK. അവർക്ക് പ്രത്യേകം ഞാൻ നന്ദി രേഖപ്പെടുത്തിക്കൊള്ളുന്നു. അതുപോലെ ഇവിടെ വന്ന കുറേ മീഡിയ പേഴ്സൺസ് ആയുർവേദശാലയെ വളരെയധികം സ്നേഹിക്കുകയും ആയുർവേദശാലയുടെ ഓരോ പ്രവർത്തനങ്ങളെയും പൊതുജനത്തിന് മുന്നിൽ എത്തിക്കുകയും ചെയ്യുന്ന നമ്മുടെ മീഡിയ പേഴ്സൺസാണ്. അവരെ എന്തായാലും അവർക്ക് നന്ദി രേഖപ്പെടുത്തിക്കൊള്ളുന്നു. അതുപോലെ തന്നെ ഇവിടെ എൻ്റെ കൂടെയുള്ള സഹപ്രവർത്തകർ, ഇവിടെ ആയുർവേദശാല ചാരിറ്റബിൾ ഹോസ്പിറ്റലിലെയും മറ്റ് ആയുർവേദശാലയുടെ മറ്റ് ഡിപ്പാർട്ട്മെൻറ്റിലെയും സഹപ്രവർത്തകർ, അവർ കഴിഞ്ഞ കുറേ ദിവസങ്ങളായി ഇവിടെ ഓടി നടന്ന് പണിയെടുക്കുകയാണ്. ഇപ്പോൾ നമ്മൾ ഈ കാണുന്ന എല്ലാ കാര്യങ്ങളും അവരുടെ വലിയൊരു നേട്ടം തന്നെയാണ്. അപ്പോൾ അവർ ഓരോരുത്തരെയും ഞാൻ ഒരു വ്യക്തിപരമായ രീതിയിൽ അവർക്ക് ഒരു നന്ദി രേഖപ്പെടുത്തിക്കൊള്ളുന്നു. അതുപോലെ ഇവിടെ ഇതിന് വിട്ടുപോയ വല്ലവരും ഉണ്ടെങ്കിൽ അവർക്കും നന്ദി രേഖപ്പെടുത്തിക്കൊള്ളുന്നു. തീർച്ചയായിട്ടും ഇങ്ങനെയുള്ള സെമിനാറുകൾ ആയുർവേദശാല ഇനിയും ബാക്കിയുള്ള എല്ലാ കൊല്ലങ്ങളിലും നടത്തി വരുന്നത് ഇത്തരത്തിലുള്ള ആയുർവേദത്തിലെ കുറേയധികം ഇൻഫർമേഷൻസ് ആധുനിക വൈദ്യശാസ്ത്രവുമായി ബന്ധപ്പെടുത്തിയിട്ടും ഒക്കെ നമ്മൾ നടത്തുന്ന ഒരു ഇൻ്റഗ്രേറ്റീവ് അപ്രോച്ച് അതിനെ ഒരു സഹായകരമാണെന്ന് സൂചിപ്പിച്ചുകൊള്ളട്ടെ. എന്തായാലും ഞാൻ കൂടുതലായി ദീർഘിപ്പിക്കുന്നില്ല. ഇവിടെ വന്ന എല്ലാ വ്യക്തികൾക്കും ആയുർവേദശാലയുടെ പേരിലും എൻ്റെ സ്വന്തം പേരിലും അഗൈതവമായ നന്ദി രേഖപ്പെടുത്തിക്കൊണ്ട് ഞാൻ എൻ്റെ വാക്കുകൾ നിർത്തുന്നു. നമസ്കാരം.
Thank you, sir. Ask at 61 concludes here. We cordially invite all of you for the lunch arranged here. Thank you all once again for your valuable presence and participation.